Good morning, everybody. Welcome. Oh,
Okay, perfect. Takes a second.
good morning, everybody. Welcome to Health Coverage Insurance. Good morning, everybody. Welcome to Health Coverage Insurance and Financial Services. We have several public hearings today, but I'd like to start with introductions from the committee, starting with Representative Mastracchio.
Good morning. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springvale.
Good morning, everybody. I'm Representative Paul Flynn. I represent House District 63, which is Winslow, Albion, Freedom, and Unity Plantation.
Good morning, I'm Rolf Olson, District 86, which is Raymond, Casco, Fry Island, and a bit of Poland.
Senator Hagan.
Hi, I'm Dave Hagan, State Senate, District 10, 12 towns surrounding Bangor, not Bangor.
Good morning, everybody. I'm Mary Grace Chimino. I represent House District 83, which includes the towns of Bridgeton, Harrison, and Denmark.
Good morning and thank you for joining us. I'm Representative Poppy Arford. I represent State House District 101, the western part of Brunswick.
Good morning, Michelle Boyer. I represent House District 123, which is most of Cape Elizabeth.
Good morning, everyone. I am State Senator Donna Bailey. I represent District 31, which is Buxton, Old Orchard Beach, and Saco, and I serve as the Senate co-chair.
And good morning. My name is Christy Mathis, and I represent District 151 in Kittery, and we welcome you to HCIFS. We will be starting with LD 2189. We're not taking anything out of order, so we'll be working as posted. The first bill is an act to require prior notification of closures of labor and delivery units and changes in maternity or newborn care services by hospitals as recommended by the Commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. And this will be introduced by Representative Boyer. Just a note, make sure that when you come up to the podium, you do sign in and that we will be running a 3-minute clock. Thank you.
Thank you, Madam Chair. And I just want to extend the invitation to committee members. If you don't hear enough from me today, happy to have lunch with anyone. It's a joke. It was a joke. It's going to be a long day of me talking. Okay, Senator Bailey, Representative Matheson, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Michelle Boyer, and I represent House District 123, part of Cape Elizabeth. It's an honor to come before you today to introduce LD 2189, an act to require prior notification of closures of labor and delivery units and changes in maternity or newborn care services by hospitals, as recommended by the Commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. I want to thank Rep. Matheson for sponsoring this measure. The language of this bill is based on the recommendations developed in the Commission reference in the bill title, which I had the honor of chairing alongside Senator Tipping. The Commission met 5 times over the course of 3 months, and its recommendations were developed with the information available during that time. It has been well reported that hospitals across the state have been closing their birthing centers. This is due to a myriad of reasons, but primarily can be attributed to financial strains on our healthcare system, workforce shortage statewide, and a shift in demographics, meaning Maine's population keeps aging while birth rates continue to decline. In the last decade, 11 birthing units have closed, primarily in rural areas across the state. 4 of those 11 closures occurred in the past year. When a birthing center or maternity ward closes in a community, it creates a domino effect. Families are forced to scramble and establish a new birthing plan. The question might become, do they move to be closer to a birthing center for easier access to care, or do they risk a longer commute to the hospital? The National Library of Medicine released a study indicating that longer commute times to the hospital can be a contributing factor to an increased risk of miscarriage and other adverse birthing outcomes. LD 2189 seeks to require notification to those who will be impacted by a change in maternal and newborn services. Current guidance from the Department of Health and Human Services, Division of Licensing and Certification is voluntary. That voluntary guidance asks that hospitals provide 30 days notice when there is a temporary closure and 100 days when the closure is permanent. LD 2189 would mandate that no matter the length of time in which care is disrupted or changed, whether it be temporary or permanent, hospitals must provide surrounding hospitals, local EMS, fire and law enforcement, as well as registered patients, at least 120 days notice. We learned during our commission work that though some hospitals were following the voluntary guidance, some were not. By ensuring that families and providers have enough time to establish contingency birthing plans in the event of care disruption, we as lawmakers are investing in the health and well-being of Maine families and the communities in which they live. Thank you for your time. Happy to answer any questions.
Questions from committee members? Representative Flynn.
Thank you, Madam Chair, and thank you, Representative Boyer. So what this does in essence is it just pushes everything out to a 120-day window. They can't close prior to 120 days.
Correct. And it takes what was voluntary guidance and makes it
Okay.
required.
All right, thank you.
Additional questions from committee members? Seeing none, thank you for your testimony.
Thank you.
Is there anybody in the room that would like to testify in favor of this bill? Welcome, Representative.
Thank you. Senator Bailey, Representative Matheson, and honorable members of the committee. My name is Gary Friedman. I represent House District 14, which is the towns Bar Harbor, Mount Desert, Lemoyne, and Cranberry Isles. And it's my honor to testify in support of LD 2189. I want to thank Representative Matheson and Representative Boyer for their work on this bill and their support for it. In the last 2 years in my district, we've been shaken by two abrupt announcements. Northern Lights closed the Southwest Harbor Medical Center, serving 1,600 patients. At that time, the head of the center was abruptly informed of the closing, not consulted. Patients learned by word of mouth. The weekly paper published a story about the closure before patients even received a letter from Northern Light. Local officials were never informed. And a year ago, decision makers at MDI Hospital closed the maternity unit without consulting nurses or patients. The head of the unit was not consulted or informed. Patients learned about it in Facebook. Local officials, again, were not consulted or informed. While this bill requires 4 months' notice when closing maternity or newborn care services, it does not require review by the Commissioner of Health and Human Services, nor provide the opportunity to hold a public hearing to determine whether a significant disruption of a health service has occurred, nor does it require reinstatement if the terms by which the service was originally improved have been violated. So I'd like to propose two amendments to this bill. One would be a requirement that the Commissioner of Health and Human Services review planned closures, determine whether they have whether they're justified and acceptable from a public health perspective, and two, that this be applicable to all closures of health services originally approved by the Commissioner. Thank you.
Thank you. Representative Olson.
Oh. Oh, I don't know. In your amendments, what time limit would you give to HHS to review? I mean, if if we're saying that they have to have 120-day notice, and now we're throwing it to HHS, who could take 6 or 7 years in their, lack of concern for anything, what time limit are you expecting there?
Thank you for that question, Representative Olson, and that's a good question. My feeling is that the 120 days is a reasonable time frame, and I'd like to see the commissioner review the request for a closure within that time frame, and at that point, there'd be a public announcement about the proposed closure.
Representative Mastrocchio.
Thank you, Madam Chair. Representative, can you tell me that first suggestion? So you want the Commissioner of Health and Human Services to review planned closures to determine whether they are justified and acceptable from a public health perspective, and then what?
Well, I have to say that I believe this the bill before us now is a result of a bill that Representative Dodge sponsored and that I co-sponsored, which would have required the commissioner to review applications from hospitals to close their maternity units or other services that had previously been approved by the commissioner. And so, what that would do is it would give the commissioner the opportunity to weigh in as to whether that was a reasonable action.
I understand that. I'm just saying, and then what? Say no, you can't do it? I'm just asking because that's not clear. Because I don't understand how you can.
Yeah, that would be my expectation.
Okay.
Thank you.
Additional questions from committee members? Seeing none, Representative Barford.
Thank you, Madam Chair. I know there's no answer to the question about, but I just feel I need to ask it. And the question is, my understanding is one of the primary reasons for these closures, it's financial. And so what do you have, along with your excellent testimony, is there a next step? Do you see a funding source up there that then, once an entity determined that the unit would not close, that unit could go to? I mean, that's what I'm saying. It's like the first step of a big movement. And do you have thoughts on what the rest of that might look like? I'm just following up on Mr.
Thank you for the question, Representative Arford. I think I'd answer by saying that, I agree with Representative Boyer's observation that the closure of these units begins a downward spiral in our communities, not only of healthcare, but of the communities as a whole. Because when you take away health services, it becomes more difficult for people to live in those communities. The people that were employed in those agencies now, are without jobs and they move. So I believe that our state has responsibility to address that problem. There is $190 million coming from the feds for, as part of the big, beautiful bill to support rural hospitals. And, it's possible that maybe some of that money could be used in the future to maintain these services.
Thank you so much for your testimony.
Okay.
Additional questions? Seeing none, thank you for your testimony. Thank you. Welcome.
Thank you. Senator Bailey represents Matheson and members of the committee. My name is Dr. Anne Marie Van Hengel. I'm here on behalf of the main section of the American College of OBGYN, representing 186 members across our state to testify in support for this bill. Maine is experiencing an alarming acceleration in labor and delivery unit closures. The causes are complex: workforce shortages, declining birth rates, financial strain, and reimbursement challenges. But complexity doesn't excuse a lack of transparency, planning, or accountability. ACOG strongly supports the intent behind this bill. When a birthing unit must close, there must be sufficient transition time. A 120-day notice period should be the standard expectation. Those 120 days establish a critical safeguard during which time Maine's experienced perinatal outreach team can bring their expertise, structured toolkit, and collaborative approach to support both the hospital and the affecting communities. It allows neighboring hospitals to adapt thoughtfully to increase patient volume. It increases emergency department and EMS time to receive obstetric training, and it allows patients to transition care safely and deliberately. A rush closure is not simply disruptive, it is unsafe. We do recognize that in rare and clearly defined circumstances, such as a sudden loss of essential clinical staff, or immediate patient safety concerns, or unforeseen financial insolvency that threatens the overall hospital operations, a full 120 days may not be feasible. In such case, any abbreviated timeline should require clear documentation and immediate coordination with DHHS to ensure patient safety remains the priority. At the same time, we must acknowledge a larger truth. This bill addresses the moment of closure, not the months or years building up to it. Birthing units do not become unstable overnight. Hospital leadership is aware of vulnerabilities well before formal notice is issued. If we wait until that notice is filed, we are already responding too late. What Maine needs is a proactive, collaborative model, one that creates a structured mechanism for early engagement with DHHS and the perinatal outreach team when a unit is first identified at risk, so every reasonable strategy to preserve services can be explored. Only when it becomes clear that the unit cannot be sustained should closure proceed, accompanied by a standard 120-day notice and coordinated transition planning, subject only to limited, well-documented exceptions as previously outlined. Our goals should not simply be to close units safely. Our goals should be to prevent closures whenever possible, and when we cannot, to manage them with foresight, coordination, and respect for the community affected. LD 2189 is an important step. With refinement to encourage earlier collaboration and carefully defined flexibility, it can help protect access to maternity care in Maine. Thank you for your time.
Thank you for your testimony. Representative Flynn.
Thank you, Madam Chair, and thank you for your testimony. My immediate thoughts were, as I'm looking at this, is we're proposing that they can't close for 120 days. But I would have to believe a hospital's decision to close a unit is not one that's arrived at lightly. They've been thinking of it, they've been talking of it, it's been a concern of theirs. Would we not be better served to require some degree of community notification 12 months or 180 days in advance of a closure, so that there could be some group get together to see if there isn't some way to head that off? So I appreciate your testimony. It's clearly one in our rural areas that we're struggling with very, very deeply right now. And it's a very, very deep concern. And I'm glad we're talking about it, but I wanted to throw that onto the table.
Okay.
Thank you.
Can I reply to that?
Yeah,
Yes.
please.
Okay. Yes, hospitals know well in advance. This is not something that is a surprise to them. There is a reluctance, from my understanding, of hospitals to make this a public announcement because it creates uncertainty and unrest within the community. And that therefore they're going to maybe lose even more staff because the staff is going to say, well, we're not going to stay here. We're going to move to a different unit because we want to keep our jobs. So too far in ahead, it causes a problem if it is public notice. What I think would be optimal would be a scenario where these hospital leadership identify the problem and have a system in place that is confidential or controlled with DHS to say, we're in trouble, we need help. Can you come with your expert perinatal outreach team, which sadly has had a lot of experience in addressing these issues, and come and look and see if there are problems, if there are solutions to problems. And there are many. So that would be my suggestion. Now, as far as letting the community know too soon, when I spoke to the perinatal outreach team, they actually say if there's too much time, it actually causes more problems. Their feeling as far as the perinatal outreach team, once a hospital has decided that the hospital has to close, 120 days is about the right amount of time that they need to be able to educate the ERs that are now going to be left without OB staff. The EMS staff, the EMS who are going to be transferring patients and also allowing patients to make meaningful changes to where they're going to get their care. And there was one other thing and I've just forgotten it. So my apologies.
Thank you. Additional questions? Seeing none, thank you for your testimony.
Thank you.
There are other people in the room who would like to testify in favor of this bill.
Here. Good morning, Senator Bailey, Representative Matheson, and committee members. My name is Lisa Harvey McPherson, and I'm here today to speak in support of this bill with an important recommendation. We participated on the commission that produced a recommendation that led to this legislation. Marie Vino, the Northern Light Regional Vice President, served on the commission, and Marie has unique experience as she was the senior leader overseeing the closure of the OB unit at Inland Hospital, and unfortunately, subsequently, the closure of the hospital altogether. During the commission, the department discussed the policy that they had regarding notice of closure of a unit or temporary closure of a unit, but they lacked authority for enforcement. So this is the genesis of the recommendation before you today, and we do support this. The existing policy states that a hospital should provide notice of temporary closure at least 30 days and 120 days prior to the effective date. But I want to emphasize the recommendation that we want to add to this bill. In cases when such notice cannot be done, the hospital should provide notice as soon as reasonably practical for a termination of service. We discussed with the commission our experience in closing the unit at Inland Hospital. We had traveling doctors known as locums, and we knew that that contract was coming to an end. We were diligently recruiting for permanent OB medical staffing, but we were not successful. Then we began diligently searching for temporary physicians to fill a contract to replace the doctors that were leaving. We were working with full intent to keep OB services open in Waterville, Maine. And when we came within 90 days of that contract ending, knowing we had no doctors, we made the very difficult decision. We had to close the service. We can't have a service that we can't staff. So we provided 90-day notice to the department, and we worked closely with the department to transition care, inform the community, work with the receiving hospitals, and work with EMS. So our example is just one example of the many reasons why hospitals may not have a full 120-day notice. Providers may leave temporarily. Surgeons may decide they're not doing cesarean sections anymore, and there may be clinical staff disruptions that can't be avoided. All can close a unit temporarily. So the bill before you today has a higher bar than the policy. It's 120 days for temporary and permanent closure. We just ask that we have the ability, when reasonably practical, to provide notice that is less than 120 days due to unique circumstances, which the department can enforce and evaluate for ill intent if need be. And I have responses to some of the questions that have been raised, and I'm out of time, so I certainly welcome your questions.
Questions from committee members? Senator
Thank you,
Boyer.
Madam Chair. Thank you, Lisa, for being here. So when it comes to like not being able to find a doctor, that just comes down to money, location, just not an available doctor. Can you help me understand that a little bit
So
better?
when we are looking for permanent physicians, we compete in a national market.
Mhm.
And recruiting OB doctors is highly competitive nationally. And sometimes Maine is a really attractive state, but sometimes it is not. And it's challenging. When we're recruiting for temporary doctors, there is an expense component to that, and that's very real. but that's a part of our strategy on how we meet our community mission. So we do recruit temporary doctors. In this case, with that contract coming to a closure in the highly competitive environment, we could not find, and we needed 2. We can't do it with 1. We needed 2 OB physicians for that contract. And we literally, with the national companies that do this type of staffing, we could not find 2 to fill that contract in time. So we closed the service.
Can I ask a follow-up? Are there less physicians going into OB care? Is that a national trend? Do you know?
I would have to find data on that to bring to the work session,
Thank you.
really.
Additional questions? I have just clarifications, if you could. So you had indicated that you provided a 90-day notice to the HHS. What happens with that notice to the community in a municipality once you
Yeah.
give that notice?
So once we provided that notice to the department, we work closely with the department and we're accountable to the department for the community notices that we provided, for working with each and every individual patient to transfer their care, to work with the receiving hospitals, largely Maine General, because this was Waterville, but not exclusively, on the volume of patients and the timeline for deliveries that would be coming their way. We had to work with the providers that were accepting those patients to transfer all of that medical information. And we have to work with EMS because EMS needs to know what hospital is a delivering hospital and what hospital is not. Not that hospitals don't deliver babies in the ED, that they do, but they would want to go to a hospital with a delivery unit if safe.
So how was the municipality notified and what was the time frame around that?
So when it comes to the municipality, it was not too long after that a decision was made to close Inland Hospital, which was an extraordinarily difficult decision. That decision had much greater engagement with the municipality.
Great, thank you. And I just was wondering, do you have a definition of what is reasonably practical?
I would say it is a reasonable standard would be within a very low number of business days in which the hospital has identified that the temporary or permanent closure must take place. I think within a few business days, the department should be notified by the hospital. Is it 5 or less? That would be a reasonable standard.
Okay, thank you very much. Appreciate Representative Artford.
Thank you, Madam Chair, and thank you for being here with us. This may be a question that is no longer appropriate in 2026, but are there other than an OBGYN, are there other levels of healthcare providers like a family doctor, et cetera, nurse practitioners specifically trained in OBGYN that are qualified to deliver babies in a hospital?
Yeah, so I'm going to answer that and I'm going to answer part of another question. So the Department of Health and Human Services has a $17 million grant right now to look at rural maternal health. And part of that grant process is the full inventory of delivering providers in the state of Maine and particularly in rural areas. And how can we strengthen those numbers? There are nurse midwives at different levels. There are family practice physicians. So this grant is the department's well-invested opportunity to use federal resources to build up this infrastructure that we really do need in our rural communities.
Yeah, but thank you so much for that information. That's actually very good news. But my question is, who is qualified to deliver a baby in a hospital setting? Is it just someone who is a licensed OBGYN, or are there other providers that are also qualified? We're talking about whether or not you have OBGYNs and if you have to have doctors from away come here, but
so what I want to do is prepare some information for you on the work session, because a really good question that's going to have a complex answer. And it's going to have a complex answer because some babies do get delivered in the emergency department. Some babies are delivered in obstetrical units with credentialed providers. Some babies are delivered in the home setting with providers who have that delivery within their scope of practice, and then there are lay midwives. So there's kind of a continuum of birthing professionals and paraprofessionals. And that is a complex answer I'd like to have for the work session.
Right, because where I'm going with this is we're talking about closure of units, which is what we're understanding
Yeah.
extremely disruptive to
Yeah.
and it's no
Yeah.
one's fault. It's not like I'm pointing the finger. So we do a lot of work in our committee about not just scope
Yeah.
expansion, but who can do what
Yeah.
legally,
Yep.
if they're trained, et cetera, et cetera. And so I'm just wondering, if we're just, who
Yeah.
else can do this work?
Yeah.
Legitimately, safely,
Yep.
et cetera, because that's clearly going to be part of
Yeah.
the solution.
That's an excellent, and like I said, I think that is worthy of a thoughtful response. What the number of healthcare professionals doesn't resolve is regions of Maine with very low birth rates, which make the safety and quality of the service at risk, as well as unfortunately liability coverage for the service itself.
Thank you very much.
Additional questions from committee members? Seeing none, thank you for your
Okay,
testimony.
thank you.
Thank you.
Welcome.
Thank you. My name is James Moorhead, and I'm here on behalf of Bill Monteo,
You didn't look
Director
like
Bill
Bill to
Monteo,
me.
who unfortunately could not be here. So, yes, thank you. Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Bill Monteo, and I serve as the Director of the Division of Licensing and Certification in the Maine Department of Health and Human Services. I'm here today to testify in support of LD 2189, an act to require prior notification of closures of labor and delivery units and changes in maternity or newborn services by hospitals as recommended by the Commission to evaluate the scope of regulatory review and oversight over healthcare transitions that may impact the delivery of healthcare services in the state. Phew. I was also a member of the commission that is putting forward this recommendation and understand the benefit that this legislation would provide. We've all heard and seen how the closure of labor and delivery units have significant impact on communities, and particularly on families who are pregnant or newly postpartum. There are appropriate reasons why sustaining labor and delivery in certain areas may not be feasible or possible, or may not be safe or possible. But there needs to be a diligent process to ensure a warm handoff of those who are impacted. The department has long advocated for additional process around the closure of these units, and the passage of this bill will codify existing department guidance for prior notice from hospitals into a statutory requirement and will add clarity to ensure timely notice for the department, patients, and community occurs. The department contemplated and put forward a very similar bill a few years ago, which unfortunately did not pass. The department would suggest that the language as proposed be placed instead under 22 MSRIA Section 1822, Notice of Voluntary Closure of Hospital, Sanatorium, Convalescent Home, Rest Home, Nursing Home, or similar institution. In our review, this is the appropriate place to incorporate this into existing regulation. I would be happy to answer any questions for the committee and make myself available for the work session. Thank you.
Questions from committee members? Representative Flynn.
Thank you, Madam Chair. The recommendation to incorporate under MRSA 1822, was that discussed within the commission?
I am not familiar. That's a good question. We'll have to.
I
bring
mean,
that
is this
back for you.
Bill's recommendation or is this a committee recommendation?
So our recommendation is to, instead of putting it into the certificate of need statute, we put it into the voluntary hospital closure statute.
Thank you.
Additional questions? Seeing none, thank you for your testimony.
Thank you.
Welcome.
Senator Bailey, Representative Matheson, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Adam Good. I'm the Legislative and Political Director at the Maine AFL-CIO. We represent 40,000 working people in the state of Maine. We work to improve the lives and working conditions of our members and all working people. Nurses and working class people in rural Maine have been hit hard by unit closures. Last March, we were fiercely critical of the announcement by Mount Desert Island Hospital CEO Chrissy McGuire that she would close the hospital's obstetrics department on July 1st. That closure followed a rash of OB closures in Maine, including at Holton, York, Northern Maine Medical Hospital, Calais, Down East Community Hospital, Waldo, and the entirety of Inland. We represent nurses and many other working class people who live in small rural communities around the state. The decision to eliminate critical healthcare services from rural working families in rural communities is devastating. We are particularly concerned that these decisions may be made without any input from or dialogue with nurses, caregivers, or other workers in the community. Things go sideways when healthcare becomes a business all about bottom line. We need opportunities for communities to think about how they can act collectively to address closures, especially when it always seems like women's and children's services go out the door first. We cannot wrap our heads around how the news of the MDI obstetrics closure was directly on the heels of the hospital announcing they were building a $35 million expansion. We know this committee is deep in the weeds of the issue of hospital closures, and there are a number of bills before you that come out of the work done by the commission. This bill stands out as a policy we want to support. There needs to be a long-term solution where healthcare is treated as a human right. In the meantime, more and more union members believe something should be done to require acute care hospitals to maintain obstetrics, birthing, pediatrics, and surgical services. I'm skipping the part where I tell you what's in the bill because some of this feels redundant. On average, patients in rural towns must drive 45 minutes one way to the nearest birthing hospital. Some are 90 minutes or more away. Labor does not go according to plan. A healthy pregnancy can turn into a medical emergency in minutes. And when that happens, patients need a hospital, trained staff, and a surgical team, and a neonatal intensive care unit ready 24/7. We know that patients in rural Maine are left hours from the nearest maternity unit, or they rely on air transport if it's available and the weather allows it. Nurses in emergency rooms are left to care for terrified obstetrics patients in crisis without proper training or equipment when units close. I'll close with this. We think the bill is important because not all hospitals are following the voluntary guidance as required in current law. When Holton closed, nurses, the public, and DHHS got 1 month's notice. Even then, the hospital executives declined to stick around to answer nurses' questions about what would happen to their patients in emergencies. I will let you read the last paragraph of my testimony. I'm happy to take a stab at any questions.
Thank you. Questions from committee members? Seeing none, thank you for your testimony. There are additional people in the room that would like to testify in favor of this bill. Come on forward.
Oh, you're tall. Okay.
Thank you.
Good morning, Senator Bailey, Representative Matheson, and honorable members of the Health Coverage, Insurance, and Financial Services Committee. My name is Lily James, and I join you today on behalf of the Maine Women's Lobby, which for over 40 years has worked to build gender justice in Maine through legislative advocacy and systems change. We are here today in support of LD 2189 and thank Representative Matheson for sponsoring this bill and the Commission for their efforts on this topic. Access to consistent, high-quality perinatal care is a key factor in positive perinatal health outcomes. However, Maine is experiencing a perinatal and maternal health care crisis. As you've heard, over the last decade, Maine has seen the closure of 11 birthing units, 4 in the last year alone, the majority of which are in rural areas. Access to perinatal health care providers is also inconsistent. More than half of Maine counties have 5 or fewer OBGYNs, and 2/3 of counties have 5 or fewer midwives. For rural Mainers, this has resulted in an average travel time of 45 minutes one way to reach the closest birthing hospital. When hospitals close or reduce maternity services with little notice, families are put at risk. As you've heard, while DHHS policy currently requests that hospitals offer 120 days notice before making major service changes, including a closure of the delivery units, this notification is currently voluntary. Just a few examples in the last year show us that the MDI L&D unit was closed with less than 100 days notice, and the Holton LD unit was closed with less than 30 days notice. For many rural Mainers, especially those with high-risk pregnancies, an L&D unit closure can be a cataclysmic event, resulting in rapid pressure to connect with new care providers, navigate wait lists, transfer care, and find alternative delivery centers with likely significantly extended travel time. This lack of continuity can significantly increase stress and put both maternal and infant health at significant risk. This notice requirement also creates more stability for hospital staff, both those employed at closing L&D units and those at the L&D units that may absorb the transferring patients. These crucial staff must have all the tools and as much information as possible to best serve their patients. Importantly, there are also already protocols built into systems to put units on diversion if they do not have, for example, the necessary staff available to safely serve a pregnant person's delivery. And a proactive 120 days notice requirement is not the mechanism to prevent L&D unit closures or from going on diversion. It is simply a more systematic, stabilizing requirement to ensure more proactive, transparent communication, giving families and hospitals the time they need to plan, coordinate care, and deliver safely. We hope you'll vote to pass on LD 2189. Happy to answer any questions. Thank you.
Thank you. Questions from committee members? Representative Chimino.
Thank you, Madam Chair. Thank you for being here. So I'm looking at this and I understand the concern about the hospital OBGYN units closing. But I also look at this and I don't see it as a remedy. To me, it's supply and demand. It costs an awful lot of money for labor and delivery units to be opened 24/7, regardless of how many people come through and use that particular service. So my question for you is, do you think if maybe the state had a more pro-family, pro-birth culture, that perhaps if we had increased people having children, that maybe we wouldn't have this problem, we would have more demand? And as that would be the case, then we would be able to go ahead and keep these birthing facilities opened.
Thank you for that question. It's an interesting question and happy to chat more about that. And, would be curious for other folks in the room from a hospital perspective. I think there's no this or that, right? Like, I think providing services and having services available needs to be the case and needs to be a consistent, available, and reliable and not stressful situation. And so this, as I said, is not about preventing L&D units from closing. It's just offering a layer of sort of a de-stressor of, am I going to find out that my OB unit is on diversion or closed on my way to the hospital, calling ahead, which, has been the case for some patients. And so, we can consider a large range of which I think the commission has been doing and other folks across the state. The TEMA grant earlier was mentioned. So this is, one drop in the bucket of the overall work happening. And I think the bottom line for the legislature, to continually be thinking about, as I know you do, is what it means to have services primarily that support women, maternity care, perinatal care, and the full spectrum of reproductive health care available and consistently available, particularly as we're seeing in rural areas where the biggest gap is currently. And so, I think that there's a number of options that lays on the table. But I think, one of the things that we would really make sure is part of the conversation is really that full spectrum of care, and that we shouldn't have to, choose one or, take money from something to put money into another bucket. We can and should do it all and fund all services. So thank you.
Additional questions from committee members? Seeing none, thank you for your testimony. Are there more people in the room that would like to testify in favor of this bill? We have somebody online. Portia? They're stuck. With them, they declined. Okay. We'll give her a second. Is she in person or? Okay, well, we'll take her up when she comes over. Okay. Is there anybody in the room that would like to testify in opposition to this bill?
Board is having technical difficulties, but if they get it straightened out, it's Representative Dodge is on the way.
Okay, great. Is there anybody in the room would like to testify neither for nor against this bill? Thank you. Go ahead.
Senator Bailey, Representative Matheson, and distinguished members of the committee. My name is Dr. Stephanie McCullough, and I am a family physician representing the Maine Academy of Family Physicians. Our members care for families in all stages of life throughout the state of Maine, and many of us, including myself, provide prenatal and obstetrical care, including surgery. This is especially true in rural areas of the state, which are increasingly losing access to maternity care as our hospitals choose to close their labor and delivery units. Our organization's position on this bill is mixed, and our support can only come with qualifications. Thus, we have chosen to testify neither for nor against. Make no mistake, we care about this problem immensely. Over the past year, the MAFP has created a task force of members dedicated to addressing this issue. We have seen our patients suffer and struggle to access care, and our members have stopped practicing in communities to whom they have dedicated their lives and careers, all because their hospitals have chosen to end maternity services. Think about that. A community loses not only their labor and delivery unit, but also loses a family doctor in the fallout from these decisions. The ripple effects are immense. The recent article from the Maine Monitor highlighted our member, Dr. Rose Fuchs, and her patient's dangerous birth experience shortly after Holton Regional Hospital stopped offering birthing services. And that's not the first high-risk birth after closure. It will certainly not be the last. The reason for our lukewarm support of this specific bill is that it does not address underlying causes of the problem or prevent it from happening. Rather, it acknowledges the problem of unit closures, but says it can just happen more slowly. Our position is that we want the state to do meaningful work to prevent any further closures from happening. The question should not be whether to continue to keep a unit open, but how to do so. LD 2189 is only a start to address the immediate fallout from a closure. We agree that it's important to ensure communication with patients, the public, and outlying hospitals if a unit is planning to close. We also agree it is dangerous to simply stop providing obstetrical services with only 30 days notice, as has happened recently. You may hear other perspectives stating it is unsafe to require hospitals to stay open for a 120-day notice period. 120 days is less than half of a full-term pregnancy. Is it fair to expect patients to transfer their maternity care halfway through their pregnancy? What about the safety concerns of a patient who now must travel many miles to deliver their baby? Although this bill is a small step in the right direction, we feel it does not go far enough. It seems to be accepting a perceived inevitability that we disagree with. We have and will continue to advocate for ways to keep maternity care in rural communities. Any other option would be devastating to rural Maine. And I'd like to use my remaining time speaking for myself to answer Representative Arford's question about scope of practice. And I want to relay that, yes, family physicians, particularly family physicians like myself who have done an additional surgical obstetrics fellowship, are very capable of independently staffing a labor and delivery unit. I have practiced in hospitals across the country where it was exclusively run by family physicians. And I implore our state to change the culture because the issue in our state is not an inadequate number of family physicians ready and willing to do the job, but hospital systems who are not open to the employment of family physicians.
Thank you. Senator Bailey.
Thank you, Madam Chair. I think you kind of hinted at the answer to my question, but you said in your testimony, we want the state to do meaningful work to prevent any further closures from happening. And the question should not be whether to continue to keep a unit open, but how to do so. So what's the answer?
I'm working on a plan right now with my employer to staff a unit entirely with surgically trained family physicians because of the difficulties in recruitment for OBGYNs. And that provides multiple benefits to a community because you can then bring somebody in who's providing primary care, which is a huge hole we need to fill in the state, but also very capable of providing obstetrical and gynecologic care.
Senator Bailey.
So just to follow up, so are there currently at the state level some obstacles to doing that?
The obstacles are not at the state level. The obstacles, as I have experienced them, are from culture and major health system, classic kind of turf war type things in medicine.
So again, what, if anything, can we do at the state level?
I've contacted my own representative to try to encourage our large health systems to broaden their willingness to employ anyone else but an OBGYN. I think that is proven through many analyses, including those by Stroudwater Associates in Portland, to be a successful means of keeping rural labor and delivery units open nationwide.
Thank you.
Representative Mastracchio.
Thank you, Madam Chair. Thanks for being here today. I appreciate what you're saying. I remember the days back when I had my kids, there were OBGYNs, there were family practice people delivering babies. They worked together in my town. We do not have, that was the first thing that closed was the labor and delivery unit in Southern Maine, in York County. And then, of course, then the hospital followed. So, I mean, I get what you're saying. But my understanding was in the 80s when they stopped doing that, the people that I knew, and I knew them personally, the family practice people stopped because the liability issues were so high. They didn't want to deliver babies anymore. And now you're saying that the hospitals are preventing that aspect? Are you're in private practice, you're not employed by the hospital?
No,
correct?
I'm employed by a hospital.
You
Yes.
are.
And that takes care of some of that liability issue. I think in private practice, it's incredibly difficult to afford liability insurance.
Right.
It's also incredibly difficult to step between a patient population in the clinic who needs you right now in front of you and a patient who's laboring on labor and delivery.
Exactly.
But that is a different issue. That is an issue of whether or not physicians can practice independently in our country, realistically, or if they need to be employed. And as
And you
we
mean
know-
monetarily because of the financial issues?
Correct.
Not that they're
and
capable.
lifestyle.
Right. And yes, because there were lifestyle issues, because those family practice people that I knew that were doing that, they were basically 7 days a week, 24 hours a day. And they might have 2 or 3 people in the practice, but they were still, I mean, those were the days where we called the doctor in the middle of the night.
Right.
Do any of you remember that? And they actually answered. There was somebody on call, which was incredibly nice. But those were the days before the internet. I mean, we're in a different place now. I'm just kind of surprised that we're not trying to think that way as well. And I guess I would want to hear in the future, like any information you have about how certain hospitals are going back, because it's a return. It's, I mean, you know, the old way becomes good again. We see that in many, many ways. So I guess I'd like to know how you see that, what we could do as legislators to help facilitate that. Because other than right now, other than subsidizing those units at the state level, like we seem to be asked to subsidize a lot of services, whether it's EMS services. I mean, in this committee, we see that because it's not sustainable model the way we're doing it now. So I would love to see any of that information that you have and how we as legislators can help that along. Because I think there's an answer there, but we do have to look back to see how we used to do it.
I love that you bring that up. I think I want to make sure I'm stepping away from the MAFP and speaking for myself now. Where I'm currently working, there are 3 family physicians doing full scope practice. I came from a group in Tennessee where there were 5 of us. There are many very sustainable models to make this work. And my community where I currently practice was another community where family physicians sort of felt excluded from labor and delivery decades ago, changed their practices so that they were outpatient only or perhaps hospitalists. And now we are coming back in to say, wait a minute, we're a very sustainable labor pool. And yes, yes. And I do want to also note that I worked at a major academic medical center here in Maine for 5 years as a residency faculty, and we have repeatedly fought to expand training opportunities for our resident physicians in family medicine, because when it comes to a labor pool, we have the largest number of family medicine trainees in our state, and improving their comfort and skill set with obstetrics is a tremendous opportunity for keeping hospitals open. As a faculty, I had multiple residents leave to go do surgical fellowships in other states with the hope that they could come back, but there were not job opportunities for them. And I can tell you from my own experience that some of the hospitals which have closed have not been willing to consider a family physician with surgical training. And that may have contributed to their labor challenges.
Thank you. Representative Flynn.
Thank you, Madam Chair. Thank you, Doctor. In paragraph 3, I want to thank you for your passion in expressing that. And I would look forward to any solutions you may have. The only question I have for you this morning is, where do you practice?
In Damariscotta.
Thank you.
Representative Chimino.
Thank you, Madam Chair. And thank you for your testimony. I do appreciate it. And I agree, Representative Mastracchio, old ways become good when you bring them forward again. In my opinion, we have become a country and a society and a state of a culture of death. Abortion rates are high. Infant rates, birth rates are low. People are not having babies. And I really feel the cure, it's supply and demand. Hospitals need to make money to be able to stay open. And do you think, in your opinion, that advocating pro-family, pro-baby birth rates as a culture, if we increased and improved that culture, if that is something that would take care of this problem?
If pro-family means paid medical leave, if it means access to childcare services so that families have reasonable quality of life, then absolutely, I think that could make Maine very competitive for young families.
Representative Jimino.
Thank you. I think that's part of it. Because that is something that I think tax incentives for people to have families and children, I think that's part of it. And I think us just making people feel like having a baby is important and worthwhile to the society, and that they're not just something to get rid of, but something that can contribute to society, doctors down the road, scientists down the road, taxpayers down the road. So I think once as a state and once as a country that we start promoting that, I think more people will have babies. And I think that's going to solve the problem. I think that's going to help us across so many strata within the state and problems that we're having. I think it's going to eliminate that. Thank you.
Representative Arford.
Thank you, Madam Chair, and thank you for your testimony. I am keenly interested in what you're saying, as it appears others are. However, I think we have moved away from the scope of this bill, which is closure, which is way in which we want to regulate notification of closure, not ways in which we could prevent the closure. So I think this is fodder for another bill, and one, if it's not able to go forward this session, I myself and others, it appears, would certainly support something like this if we're here in the next session. But I do want to comment on the fact that I started this by the questions because I'm keenly interested in what we can do to prevent closures, but that is not the scope of this bill. That's my understanding, at least.
Is that a question?
So my question is, would you be interested in further exploring with legislators ways in which we can prevent closures?
I would be delighted.
Thank you.
Thank you. Additional questions from committee members? Seeing none, thank you for your testimony. Is there anybody else in the room who'd like to testify on behalf of this bill? Welcome, Representative.
Good morning, Chair Bailey, Chair Matheson, and esteemed members of the Health Coverage, Insurance, and Financial Services Committee. My name is Jan Dodge, and I represent House District 39, which includes Belfast, Northport, and Belmont. Thank you for this opportunity to testify, and thank you to the members of the Commission. I appreciate your work and this bill that you have brought forward. Several Maine communities have experienced the loss of maternity services at their local hospitals. These situations create stress for expecting parents and families. Reduction in access to services and hospital closures also negatively affect residents' views of their communities, as well as influencing the marketability and growth opportunities for the affected municipality and the surrounding area. Please pass this bill to ensure that the people of Maine will have at least the notification to allow them to craft appropriate treatment plans, make the hard choices to guarantee their very best birthing preparation and delivery and aftercare health decisions. I also strongly urge you to amend the bill to include review by the Commissioner as part of this process. From the beginning, my bill, this is about an inverse certificate of need and the review of the removal of services. Thank you for your time. I will try to answer any questions you have.
Questions from committee members? Seeing none, thank you for running over.
Thank you.
Thank you. Are there additional people in the room who'd like to testify?
Portia
Is Portia here?
Yeah.
Okay. Oh, okay, go right ahead. Are you neither for nor against?
Yes.
Okay. I'll pull Portia over after.
Senator Bailey, Representative Matheson, members of the committee. I'm Sarah Calder with Maine Health I was not planning on testifying today, so I can submit written testimony. Maine Health supports the amendment that Lisa Harvey McPherson presented to this committee. We do not support the amendments that have been discussed today, and the commission didn't support those amendments that have been presented. So I wanted to make note of that. There were some questions that were raised that I'd like to take a moment to address. This is not a financial decision. It's really a vicious cycle that's based on volume, and that impacts our ability to recruit and retain our care team. If this were a financial decision, I think that the hospital community would have been here right away with a bill to increase reimbursement rates. I think we would have had the support of the legislature to do that, but it's not financial. It's really based on volume. And it's not just the providers that are delivering the babies. We need to have a pediatrician. We need to have anesthesia. That has to be available 24/7. Those people have to be on call, and they want to deliver babies. And if they're not delivering babies, it makes it really hard to retain them and to recruit individuals. I'm looking at my chicken scratch. Also wanted to mention, and we've talked about it in this committee before, the Merge Collaborative, which is a partnership between the 4 teaching hospitals in the state, looking at increasing residency opportunities. We are looking, I believe, and I will double check, expanding the practice and training for family medicine providers to have a special training on OB deliveries. So I can get you more information on that. Making sure I covered everything. I'm happy to answer any questions, and thank you.
Thank you. Representative Mastracchio.
Thank you, Madam Chair. Can you tell me, is it pretty much a policy now that family practice physicians, because I mean, I think about my family, the family practice physician, the practice that I went to, and they delivered babies, they did the necessary whatever. I mean, if there was an issue and they could send the people to Portland. They also they acted as pediatricians. I mean, they had all that training. Why is it that we can't see that model worked? Because what you're saying is you can't deliver a baby, you can't have a birthing unit unless you have all those other specialties, but we did. And why can't we now? We used to. That's the way it worked. So I'm just saying that we know we're having a problem. So why aren't we trying to look at that issue instead of we just are at, and then it wouldn't matter as much that the birth rate is going down, because they'd be busy in all those other ways that they take of the continuum of care from birth to death, which is what family practice physicians did. So just tell me why that isn't a workable, something to work forward for in a hospital.
And Lisa mentioned the grant that the state received. I know that there is a lot of planning work that is taking place right now. And as I mentioned, I believe, and I will confirm, that there are training opportunities today through this Merge Collaborative to try to expand access to the training opportunities for family medicine physicians in rural areas so that we can continue to use family medicine physicians to deliver babies. I mean, recruitment is a real challenge outside of OB. We are challenged in Maine to recruit physicians. We do not have enough residency slots in Maine. We don't have enough training opportunities. But I can get you more information.
Yes. We're never going to fix it though if we just say we can't do it. So I think that we need to figure it out, because it's not going to get better if the answer is, let's just close it down. Because that creates a whole bunch of other issues in every aspect of the lives that people are living in those rural areas.
I don't want to give you the impression that we're saying it can't happen. I believe that the work is happening.
And we're saying, involve us in that process, because that's what we're here for.
Yeah, no, and I will bring back information to this committee.
Representative Boyer.
Thank you, Madam Chair. Thank you, Sarah, for being here. I hear you say that it's not about the money. Have the hospitals looked at using doctors that are in Portland or more, populated areas? And having them do, a week at a rural hospital or something like that. Like, it seems like if money isn't the issue, why can't we take doctors that we have here and use them in rural instances from time to time or as some sort of rotating schedule? Is that something, like, you don't have to give me a big answer, but is that something hospitals are looking at?
I will say that we made the very difficult decision to close the inpatient delivery services at Waldo in Belfast. In order to sustain the services safely, we had to use providers coming up from other hospitals to provide that care. Again, I think it's a recruitment challenge. I mean, if you want to practice in Portland, do you want to spend a week of your life being on call in a rural area? That's a decision that may weigh heavily on a provider. I think we looked, and I can't speak for hospitals outside of the main health system, but I think we looked at every available tool in our toolbox to try to sustain that service safely.
Representative Chimino.
Thank you, Madam Chair. Thank you, Sarah. Maine Health has 4 slots. Is that it per year for OBGYNs?
How many residency positions?
Yes.
I don't know the number off the top of my head. I can get that for you.
Okay, and also if you could, how much does it cost to actually keep an OBGYN unit opened on an annual basis?
I can get that information for you as well.
Thank you.
Other questions? I just had a clarifying question. So you indicated that the commission didn't support the amendments that have been considered?
I don't believe they didn't move I know it's not moving the question. They didn't, it was on your list of recommendations, but they didn't vote. I think my memory is not great. But I can go back and look, I believe, because they knew that they didn't have at least majority support to move the proposal. And so they didn't take it up. It was on the list of recommendations. So the way I interpret that is it was not the recommendation of the commission to accept those 2 proposals.
So I just want to be clear. So we're talking about the reasonably practical time frame and the movement of the language, or what other amendments are you?
No, to expand the review to all services, not just OB services.
So that's the movement of the language that the department put forward? No?
No, I
Okay.
don't think so.
Okay.
And then the second one was having the department review the closure notice.
Great. Thank you very much. Any other questions? Thank you for your time.
Thank you.
Is there anybody else in the room that would like to testify on behalf of this bill? And is Portia? Okay, great. Why don't we bring her in?
It's the other.
Welcome.
Oh, hello. Hi.
Hi, welcome.
Good morning. Thank you so much for coming back to me while I dealt with some technical difficulties. My name is Portia Judson, and I've been a registered nurse for 10 years. I work at MDI Hospital, Mount Desert Island Hospital's emergency department, and I'm a member of the Maine State Nurses Association. I'm testifying in support of LD 2189. As you know, Mount Desert Island Hospital closed its OB department in July of this past summer. Our hospital can't really serve our entire community without our OB, but after the closure, I had a patient come in. She was about 23 weeks pregnant. She was having profound abdominal pain, and she was absolutely terrified. She'd had a history of difficulty with prior pregnancies. And as I was, initiating her care and doing her triage, she was asking me why I wasn't hooking her up to that machine with all the little wires that goes across her belly, or the band that goes over her belly. It's a fetal heart rate monitor. And when I said, well, we don't have access to that anymore, we don't have anybody to run it, she was very polite. She asked me to step out of the room and send her husband in. And then she stated that she was leaving because we didn't have the ability to care for her. I was able to turn that around to get her to stay, and we were able to get her issues resolved. But Her terror was absolutely stark, and I couldn't tell her. I honestly couldn't tell her that if there was an emergency, we would be able to get to definitive care, that we could get transport, or that we would be able to get her somewhere in the amount of time that might be needed. So this is why we need OB care in hospitals for our whole community. We thank the committee for this first step addressing the critical problems of OB closures. When MDI closed its OB, the community got about 3 months of advance notice. When Holton closed its unit, the nurses and community got only about 1 month's notice. Nurses like me in the ER, nurses at the hospitals where our patients go, and the pregnant patients all end up scrambling to deal with the fallout. The 120-day notice requirement will give healthcare workers, patients, communities, and policymakers time to ask questions about the closure, look for ways to prevent it, and make plans to address the harms of the closure. Our patients need time to make alternative plans for prenatal care and birth, which is not easy in rural areas where options are few. Hospitals that are closing units will have to show that they have plans for maternity emergencies, including training for emergency department staff. A healthy pregnancy can turn into a medical emergency in minutes. As a nurse in the emergency department, I want to know what we can do for patients when they inevitably come in with these emergent maternity care needs. Other hospitals also need time to prepare for new patients. Nurse colleagues at hospitals that still have OB units have had periods of being overwhelmed by increasing patients coming in from areas where the OB units have closed, or where hospitals are on diversion, with no extra resources provided to care for them. Finally, the information collected from closure notifications under this bill will help Maine plan to prevent future closures. MSNA is ready to continue working with legislators and policymakers to create a long-term solution to rural maternity closures. Today, we ask for your support for LD 2189. And I thank you all very much for your time.
Thank you for your testimony. Are there questions from committee members? Seeing none, thank you very much.
Thank you.
Is there anybody else in the room that would like to testify in any capacity for this bill? Seeing none, does the committee have questions for Colleen for the work session? I had one quick question or just clarification for the work session. If we did move this out of this language, how does that impact all of those services that? Okay, great, thank you. Okay. Great. Then we will close the public hearing on LD 2189 and open up the public hearing on LD 2162, an act to regulate and prevent children's access to, oh, sorry. No, sorry. I'm on yesterday. 2190. I was like, oh, wait a second. That seems strange that we're doing AI. An act to implement certain changes in the certificate of need laws recommended by the commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. And Representative Boyle will present this. That makes more sense, doesn't it?
All right, good morning again. Senator Bailey, Representative Matheson, members of the Health Coverage Insurance and Financial Services Committee. My name is Michelle Boyer and I represent District 123, part of Cape Elizabeth. It's an honor to come before you today to support LD 2190, an act to implement certain changes in the Certificate of Need laws recommended by the Commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. LD 2190 seeks to expand the criteria considered during a review under Certificate of Need laws to include how the project might impact Mainers' ability to afford and access healthcare services. Currently, the CON program is designed to control costs to the state and therefore focuses on the financial impact on the state's main care program. During the commission's work, it was learned that CON does not consider and analyze how a proposal may affect healthcare costs for all Maine consumers. As it is well reported, the consolidation of healthcare systems has increased costs for consumers. This bill does not include definitions for affordability and access, and those terms will need to be fleshed out by this committee if they were to move this forward. It's also important to note, as changes to CON are contemplated, that the state CON department consists of one full-time employee. Thank you for being here, Mr. Lawrence. If the committee chooses to make changes to CON and expand the scope of review, it will be necessary to ensure additional resources are available. Thank you for your time, and I'm happy to answer any questions.
Questions from committee members? Seeing none, thank you for your testimony.
Thank you.
Is there anybody in the room that'd like to testify in favor of this bill? Welcome.
Good afternoon, Senator Bailey, Representative Matheson, members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Trevor Putnaki. I'm the CEO of the Healthcare Purchaser Alliance of Maine. As you probably already know, we're a nonprofit organization created by employers and public trusts in the state with a broad mission of trying to advance quality access and affordability. Key to affordability in the state of Maine. We represent about 150,000 commercial lives in the state. I also would note that I had the honor and pleasure of participating on the commission over the last year, and so was part of many of the discussions around the bills that we'll be considering here today. On this one in particular, I would note, current CON law does allow the Department of Health and Human Services to consider the impact of proposed projects on healthcare affordability and access for Mainers, but they are not required to do so. 2190 would amend the law to require that CON reviews take that impact into account, which frankly, I think is really a common sense measure given the impact of affordability on people in Maine. As you heard me say before, we have the fourth highest family deductibles in the country now. Average family premiums in Maine are around $25,000, which is the equivalent of buying a brand new Honda Civic for every family in Maine every year. The costs have gotten really out of control. It's now about 10% of household budgets are going to healthcare expenses, and about 1 in 4 Mainers have reported that about 40% of Mainers have reported that they're skipping or delaying care due to costs. It doesn't take more than a cursory review of the Maine Health Data Organization's Compare Maine website to see how prices vary around the state, depending on where patients seek care. We saw on their website, the average price for colonoscopy, for example, is $6,525, with the average facility price ranging from a high of $9,804 at one hospital to a low of $1,869 at an ASC located just 20 miles away. The average price of knee replacement is about $50,000, with a high of about $67,000 and a low of about $28,000 at an ASC. Now, I know the committee already voted to raise the threshold for CON reviews, which I think is a great idea to bring in more competition and more affordable options into the market. But I think that having affordability be a consideration for projects that do hit the CON threshold is really an important function of the review that takes place. There have also been numerous studies, and I've included some in my testimony, showing how prices vary by site of care across the United States. And I think, as we consider expanding services, it just makes sense to consider the impact on affordability for consumers and businesses in the state. So with that, thank you for the opportunity to share this testimony. I'm happy to answer any questions, and I will be available for the work session.
Questions from committee members, Senator Bailey?
Sorry. I forgot to mention one important thing here. The statute says that it would require that the project does not negatively affect the affordability of accessibility of healthcare services for all residents of the state. I think negatively impacting affordability and access is certainly important, but we think the department's review should also take into account whether a project would positively impact affordability and access. I think that should be the goal here, is whether a project is going to bring more affordable care, not whether it's going to negatively impact affordability. Thank you.
Senator Bailey?
Thank you, Madam Chair. So in looking at the commission report, it was noted in this section that the commission noted that it will be important for the legislature to consider how to define the terms affordability and accessibility for the purposes of analyzing how a proposal may affect healthcare costs and access to services. I don't see a definition of affordability and accessibility in the bill. So how should we define those?
Yeah, I mean, affordability is a tough word to define, right? Because it's so specific to individual circumstances. But I do think that with the Maine Health Data Organization's wealth of data around prices, that you could look at the average price of a service within a geographic service area and require that the submitter of the CON application includes some information on the prices that they intend to charge for their services, compare that against the available prices within that geography, and determine whether or not they represent a more affordable option for consumers.
So you think we should just look at the rack rate, if you will, not, I mean, you put in your testimony information about health insurance premiums.
Yes, and premiums are being driven primarily by the prices that we pay for medical services. So ostensibly, if you have a lower price option in the market, employers and consumers will spend less total on healthcare, and premiums thus will go down. I mean, premiums are really based on the underlying price, largely of services within the community.
They're based on the negotiated rate. They're not based on the actual.
Yeah, I mean, that's a total valid point, but I think those negotiated rates start from a rack rate often. I mean, the carriers are negotiating percentages off the charge master in a lot of cases, not in all cases. But if the sort of rack rate is lower than the rack rate at the other provider in the market, then I would assume, I think it would be pretty safe to assume that the insurers are going to negotiate a discount that would be below what their negotiated discount at the higher charge master organization would be.
I think that's accurate. And actually, most studies have shown that the information about prices is primarily used by providers, hospitals in particular, and insurance companies in their negotiations, and not used by consumers. So again, I'm struggling with the definition of affordability and accessibility. And so if you have any suggested language, I'm kind of surprised that the commission put this out there as something that needed to be addressed, and yet they didn't address it. So
I think we all wished we had a lot more time on that commission to get more into the weeds. We could talked about a lot of different potential policies over the course of, I think, what do we have, 5 meetings? So yeah, I'd be happy to take that back and suggest a potential definition of affordability, or look at ways that could be measured.
Thank you.
Great.
Additional questions from committee members? Seeing none, thank you for your testimony.
Thank you.
Are there additional people in the room that like to testify in favor of this bill?
Good morning, Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage Insurance and Financial Services. My name is Kaylee Shea, and I'm a policy analyst at the Office of Affordable Healthcare. Thank you for the opportunity to testify today in support of LD 2190. Under current Maine law, certain healthcare facility expansions, new services, or other projects must first be reviewed and approved under the Certificate of Need process, as you are all aware. This bill would add new considerations to that review, including impact on affordability and accessibility of healthcare services for all Maine residents.
Healthcare costs continue to place significant strain on Maine families and employers. When facilities expand, change services, or change ownership, these transactions have the potential to meaningfully impact prices, utilization, and system-wide spending. By explicitly requiring the department to consider whether a proposed project would negatively affect the affordability of healthcare services for Maine residents, this both strengthens the CON framework to better align with an increasingly complex and expensive healthcare system. A given transaction's effect on affordability is not an abstract concept. These impacts can affect whether individuals can seek timely care, whether employers can continue to offer coverage, and whether state budgets can sustain critical programs. Including impact on affordability and CON review ensures that the long-term implications of transactions are evaluated appropriately. Other states provide clear examples of how impact on affordability can be incorporated into healthcare market oversight programs. The Massachusetts Health Policy Commission conducts cost and market impact reviews of significant healthcare transactions and examines whether a proposed merger, acquisition, or affiliation is likely to increase prices, enhance market leverage, or otherwise raise costs for consumers. Massachusetts evaluates impact on affordability by analyzing projected price effects, changes in negotiating power, and the anticipated impact on overall spending. Likewise, the Oregon Health Authority reviews healthcare transactions to determine whether they are likely to increase consumer costs, reduce competitions in ways that could drive up prices, or limit access to reasonably priced services. Impact on affordability is treated as a substantive review factor assessed through evidence about pricing behavior, financial incentives, and the expected downstream impact on patient purses. We also have one more example in there from California, but I will save you some time and skip over that one because it's quite similar to Massachusetts and Oregon. But to wrap up, LD 2190 would allow Maine to follow the examples of these other states by ensuring that CON review explicitly considers how proposed projects and ownership changes may affect the cost of care for Maine residents. For these reasons, the Maine Office of Affordable Health Care supports LD 2190. The office would also note, however, that LD 2190 creates potential for overlap with LD 2201, which you will have a hearing on later this afternoon, particularly given the two bills could trigger different procedural reviews for the same transaction, one being the CON review with expanded criteria that we're discussing in 2190, and the other being a cost and market impact review included in LD 2201. While the office generally supports more intensive reviews of these transactions, we believe the more detailed structure outlined in LD 2201 would be the best model moving forward. Thank you for your time, and I'd be happy to answer any questions.
Questions from committee members? Senator Bailey.
Thank you, Madam Chair. So I'm going to ask the same question I asked Mr. Putnacki, because how do we define affordability and accessibility? And if your office could perhaps work on that and give us some suggestions for the work session, that would be very helpful.
Yeah, happy to look back also at the rules and regulations for Massachusetts, Oregon, and California to see more explicitly how they make those definitions clear, and I can bring back more information for the work session. Thank you.
Thank you. Additional questions from committee members? Seeing none, thank you for your testimony. There are additional people in the room who would like to testify in favor of this bill.
Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield, and I appear before you to testify in support of Section 6 of LD 2190. I too had the pleasure of serving as a member of the Healthcare Oversight Task Force. I think that was our shortened name. I don't even remember our official name. And this was one of the issues that we discussed. And certainly, if the state is going to serve as the gatekeeper for the development of new services for the state, then it needs to look at the impact of those services on more than just the main care program. As Representative Boyer indicated in her testimony, we learned through the task force work or the commission's work that currently the Department of Health and Human Services, when evaluating CON applications, only looks at the impact to the main care program. We would suggest that in addition to the language in Section 6, that a parallel provision also be added to subsection 5A of the same statute, subsection 1H deals with sort of the standards for approval, but 5 deals with the record. So we believe that the record should also reflect the department's evaluation of the impact on affordability and accessibility. And how to define affordability and accessibility, anticipating Senator Bailey's question. I do think that Mr. Putnaki might be on the right track, and that looking at the rack rate might be sort of a proxy for accessibility and affordability, even though, you know, we often negotiate reimbursement rates that are based on a DRG basis these days, and value-based payments. It's important to remember that this review and evaluation won't impact just the insured, but also the uninsured, and they do pay the rack rate or a discounted version of that. So I will be happy to take that back and look at, come back with some suggestions around how to define affordability and accessibility, but I do think the so-called rack rate might be a component of that. And with that, I'd be happy to answer any questions, and we'll be here at your work session as well.
Thank you, Ms. Osforth. Is there any questions from the committee members? Seeing none, thank you for your time. Are there additional people in the room who'd like to testify in favor of this bill? We don't have anybody online in favor, correct? Is there anybody in the room that'd like to testify in opposition to this bill?
Good morning, Senator Bailey, Representative Matheson, members of the committee. I am Andy McLean. I serve as CEO of the Maine Medical Association, and I'm here today to speak in opposition to LD 2190 on behalf of the MMA and the Maine Osteopathic Association. I'm going to ask your consideration that I not have to sign in. That'd be rather difficult for me. We have submitted written testimony, again, with apologies. Before receiving the instructions, we framed our testimony in opposition to both LD 2190 and 2201. I am going to speak to both. And what I'd like to do is talk about increased regulation in the healthcare sector, generally speaking, first, and I'll defer, at least my intention is to defer any comments I have about private equity financing to 2201. So you'll recall that in our testimony on LD 1972 last session and in our preliminary comments to the Health Market Oversight Commission, we expressed general concern about increasing the regulatory burden on Maine's healthcare sector. Today, I'd like to ask you more specifically, as you're thinking about and deliberating these bills, think about policy decisions that will support an environment in which independent private physician practices in Maine can thrive. Our professional organizations represent physicians across the state of Maine, all geography, all medical specialties in every practice setting. We all have witnessed the market forces that have compelled the consolidation in our healthcare sector and the demographics of the physician population that have affected decisions that they make. The vast majority of our members are happily employed in one of the health systems, an independent hospital, or one of Maine's terrific FQHCs. But there is a place, we think there is a place for private practice in Maine, and we need to do our best to promote an environment in which they can thrive. These are all strong members of ours. They're significant parts of your communities. These range on the larger end from organizations like Spectrum Healthcare Partners, Martins Point, Intermed, a series of specialty practices in southern Maine, including, for example, New England Cancer Specialists and others. to small micro practices, single physician practices, whether they are traditional or in the direct primary care model. You heard from one of those physicians on my executive committee, Dr. Elizabeth Pierce, who came before you to speak about LD 1890. So all of this to say about our CON process, without meaning to offend the CON unit or anyone, CON at its core is a blunt instrument about supply of healthcare services and their relation to cost at the global level. I simply don't think that adding difficult, and Senator Bailey has raised this question several times already this morning, these difficult qualitative questions of defining accessibility and affordability. I worry about one of our members in private practice trying to demonstrate that they have satisfied these new factors in our CON framework.
Do me a favor and finish up. Thank you so much.
Thank you. Happy to answer any
You
questions.
didn't need to finish right at that point. You can complete your sentence.
Well, I just that you know what I was going to say, that you add every new factor you add to the framework is going to mean potentially new consultants, experts that have to be brought in by the applicant to try to demonstrate that they have met an accessibility or affordability standard.
Thank you very much. Questions from committee members, Representative?
Thank you, Madam Chair. But I mean, I guess where my question would be in here is, if someone is adding a new service, they're not doing it in the blind. They're doing it from the standpoint that they've already assessed what's out there, what's available, what they're going to be offering to do that. So a lot of that work they would have already done, or they wouldn't be in the position of saying, we want to go ahead and do this. So to say that's adding a whole level, I'm not sure where I get that that's adding a whole new level of requirement upon them.
That's a valid point, but I don't know that the analysis that a practice would do in making a business decision about whether to try to open a new facility is the same level that would be required to meet the standard of a public process. I think the point that Dr. Pierce was making in LD 1890 is that there simply isn't enough, for example, OR time available in the community. And if she could assemble the capital, or she and other independent practitioners, perhaps they should be able to build an ASC.
Additional questions from committee members? Seeing none, thank you very much for your testimony. Are there other people in the room that would like to testify in opposition to this bill?
Senator Bailey, Representative Matheson, and members of the committee. I'm Sarah Calder with Maine Health, and I'm here to testify in strong opposition to Section 6 of the bill before you today, and then to offer an amendment to strengthen our existing CON law. First, with respect to Section 6, the CON process already considers both access and affordability. Under the current law, the CON unit must evaluate whether a proposed project will be accessible to all residents in the area, and what impact it will have on total healthcare expenditures. In fact, and during the work session on LD 1890, Director Monteo made clear that lifting the new healthcare facility threshold would actually limit the department's ability to review payer mix and assess whether a proposed facility could negatively impact an existing provider that cares for all patients, regardless of insurance coverage or ability to pay. The department also already has and uses its authority to impose conditions to protect access and affordability. In past transactions, which I've linked in my testimony, which always does you no good because it's on paper, so I will send you those links. It has required hospitals to maintain specific service lines for a defined period of time to prevent reductions in care following a transaction. And then in addition, during the Attorney General's review of a transaction, they often retain independent economists to analyze market concentration and potential price impacts. So the authority proposed in Section 6 already exists, and it's being exercised. Section 6 also assumes that an acquiring entity can determine in advance how prices will be affected by a transaction. In reality, that's simply not possible. In merger or acquisition transactions, the acquiring entity does not have access to confidential commercial insurance contracts before closing. More broadly, no single provider controls what a patient ultimately pays. Out-of-pocket costs are influenced by insurers, employers, benefit design, and negotiated rates. And it's impossible for any applicant to predict with certainty how each patient's prices will evolve post-transaction. At the same time, as we've shared with this committee many times, Maine's nonprofit, mission-driven hospitals are at a breaking point. When a hospital or service line is financially distressed, the options are stark. It's often acquisition and stabilization or closure. Maintaining sustainability may require negotiating new reimbursement rates to preserve services, and the current CON framework allows the department to weigh these trade-offs thoughtfully and impose tailored conditions. So we urge you to strike that section from the bill. The amendment that I would offer, you heard this in the work session on LD 1890, that these lease arrangements, and actually Director Monteo was the one to raise it, these lease arrangements for equipment and facilities are increasingly being used, and because of that, they're not triggering the CON review. So if the legislature does raise the thresholds, as is in either report proposed in 1890, this practice will only continue to grow. In the Portland area, several recent projects have avoided review through these lease structures, which has eliminated the department's ability to assess their impact on Maine's already very fragile nonprofit healthcare system. I think relevant to this conversation on access and affordability. So we would encourage you to use perhaps this vehicle, LD 2190, as a way to add in those lease transactions as part of the threshold consideration for a CON review. I'm out of time, so thank you so much. I'm happy to answer any questions that you may have.
Thank you. Questions from committee members? Yes, Representative Boyer.
Thank you, Madam Chair. Thanks again, Sarah. So in your testimony where you talk about the Attorney General's review of a transaction, are you stating that the Attorney General reviews every transaction?
Just the transactions that are merger or acquisition that would trigger the FTC requirements.
And can you remind me what that amount is? I'm guessing it's tied to a dollar amount.
I'm actually not sure if it's tied to a dollar amount. I can get that information
That
for
would be
you.
great. Thank you.
Additional questions from committee members? Seeing none, thank you for
Thank
your
you.
testimony. Are there additional people in the room that would like to testify in opposition to this bill? Seeing none, I think we have somebody online. Wanda? Great. If you could bring her over, Edna. Thank you.
Good morning.
Good morning, Wanda.
All set to go?
Yes, thank you.
Okay. Good morning, Senator Bailey, Representative Matheson, and honorable members of the committee. My name is Wanda Pelkey, and I'm the CEO of First Atlantic Healthcare. Today, I'm providing testimony in opposition to LD 2190. Our company is a Maine-based company that owns 17 nursing homes and res care facilities throughout the state. We care for about 1,500 residents each day. While I'm opposed to this bill, I'm generally supportive of the protections of CON. And for the purposes of my testimony today, I am speaking specifically about nursing facilities. Section 9 of this bill requires an expanded evaluation be completed When a change in ownership or control involves private equity or a real estate investment trust, I believe this is redundant with existing authority and current CON rules, which as part of the application process already requires that a healthcare entity demonstrate that the project is owned or managed by an entity who is fit, willing, and able, is economically feasible into future years, and fulfills a public need with efficiency and quality outcomes, to name a few. In turn, as authorized, DHHS can already, under existing law and regulation, request additional information and extend the review if necessary, and ultimately only approve applications that satisfy those tests, including setting additional approval conditions if warranted. So the current process already provides broad authority to conduct deeper reviews in its approval process without the need for this bill, really for any reason that DHHS deems necessary. You know, I worry that bills like 2190 and others you'll hear today are depicting private equity and REIT ownership and financing as categorically harmful to Maine's healthcare delivery system. Making law based on a prejudice like this will be damaging to our system if it outright prohibits certain financing structures or bars or limits certain capital investments or entity types. I then worry that investors may avoid Maine altogether due to high barriers of entry and unfriendly policy. Current owners could lose an important source of capital, especially in this current climate, where commercial banks are wary of lending to healthcare entities that rely heavily on Maine care payments. I can't see how much time I have left, so cue me if I'm over my time.
Got about 20 seconds left. You're good.
Okay. Perfect. You know, over the last 11 years, about 29 nursing facilities have closed, and each of those have closed due to inadequate Maine care rates. I feel if we really value statewide access to care, we should prioritize adequate and stable Maine care funding rather than creating friction through regulations. I specifically list down some of those ideas. Some of those are cost of living adjustments, true access to a financial safety net from the state of Maine. But saying it simply, just ensuring sustainable Maine care rates, I believe, is a far better way to retain needed healthcare services and preserve adequate access to capital. I thank you for the opportunity to speak before you today. I'd be happy to take questions.
Thank you very much. Questions from committee members? Seeing none, thank you very much for your time.
You're welcome.
If anybody in the room would like to testify neither for nor against this bill? Thank you. Okay, thank you. Welcome.
Good morning, Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Rich Lawrence, and I'm testifying on behalf of Bill Monteo, the Director of Division of Licensing and Certification, who can't be here this morning. While the department understands the intent and shares the concerns that precipitated the commission recommendation and later this bill, the department wants to make the committee aware that passage as written will create conflict with other sections of the statute and with current contracting processes. The addition of the new requirements in this bill would create conflict and challenges with existing requirements as follows. Reviews currently look at the ability of the applicant to financially support the project over its intended useful life and its impact on healthcare access and the geographic location it is proposed to function to a statewide analysis. This bill would change that, and a review would now focus on ensuring the project does not negatively affect the affordability and accessibility of healthcare for all residents in the state. This new type of review could not be reasonably accomplished in the current 90-day review timeline. The department will need additional resources and time for a review in order to accomplish the statewide analysis as proposed. The proposal would require the department to contract with a consultant to do this analysis. The consultant would be funded by the applicant and would investigate activities in the conduct of private equity and real estate investment trusts associated with an applicant. Finding and hiring that kind of consultant would require the department to engage the state's procurement process, which requires more than 90 days. While the bill would require the applicant to fund a consultant, it does not indicate that the applicant will fund the state cost associated with conducting and completing the RFP process to engage the required consultant. The department would recommend that the committee consider passing LD 2201. Again, I think we're going to discuss that today. Instead, as the goals of this bill, including analysis related to affordability and accessibility, an increased review of private equity-related healthcare transactions may be more effectively met by that proposal. Thank you.
Thank
Be
you.
happy to take any questions.
Thank you very much. Questions from committee members? Seeing none, thank you for your
Thank you.
testimony. Are there additional people in the room like to testify neither for nor against? Thank you.
Senator Bailey, Representative Matheson, members of the committee, my name is Jeff Austin. I'm here on behalf of the Maine Hospital Association. I want to speak mostly to Section 9, which we support, which is on the consultant. And if I have time, I'll talk briefly about what you've mostly been talking about, which is Section 6 and the 2 new criteria. Section 9 is essentially our testimony for the whole day. We think this is what you should do. You don't need new offices, standards, criteria, or review systems. What the commission heard was that private equity transactions can be very complicated. I don't think you need new standards. But when these, as yet to happen with hospitals, rare private equity deals do come through that are subject to our existing reviews by CON unit and the AG, it probably makes sense to bring in a consultant, accountant, somebody with some expertise in private equity transactions who can tear that deal apart and find undue risk. That's what they heard about, that there are different ways these transactions can go. They have different tools to use to create unnecessary risk to extract profit out of the deal. I think the CON unit and the AG's office would benefit from having a private equity expert along for the ride. The standards are there. The criteria are there. The offices are there. These deals haven't happened in Maine like they have in other states at the hospital level. To a small extent, they are happening in nursing homes and private practices, but not at the hospital level. And I personally don't think they're going to happen much here. But in the event they do, I don't think you need to build a whole new system for it, but they should have the expertise available to help them while they tear the deal apart. I think the department's concerns about the procurement timeline and all the rest can be easily dealt with. You can either exempt it from procurement, which happens. You could ask them to pick a consultant for the whole year at the beginning of the year. They don't have to do it with each deal. These aren't going to happen very often. There's not a big universe of people who would do it. I think that's your answer to most of the bills you're going to see today. Just arm them a little better in case these deals come along. As for Section 6, my colleague Sarah, I think, handled most of it. I would just say we're where Senator Bailey is. There's no definition of affordability. It's very hard to respond to it. I would say that what Mr. Putnaki and Ms. Ossenfort said was completely wrong. It is not just the rack rate. Healthcare spending is 2 factors, price and utilization. Any affordability definition that only looks at price is skewed and slanted. The research is out there. There are for-profit competitors who can come in at a lower price, but they so drive up utilization that overall affordability gets worse. That's been studied and it's true. So we don't think you need to do those extra criteria for all the reasons Sarah said. We just think in those rare private equity instances, you might want to have a consultant available to the state agencies to help them.
Great. Thank you, Mr. Austin. Questions from committee members? Representative Boyer.
Thanks, Madam Chair. Thank you, Jeff. I guess I'm confused because what I just heard Mr. Lawrence stand up and say is that this bill would change what CON is currently looking at. And the review would now focus on ensuring the project does not negatively affect affordability and accessibility of healthcare for all residents in the state. So I guess I'm confused by your assertion up here that this is what they're already doing.
It can be done, whether they're doing it to the,
Okay, but that's different than it's being done, which is what I heard you say.
we don't think you need to add these standards. We're not in favor of Section 6.
I understand that, but I don't want this committee to think that it is being done now.
I think when the issue is raised, there's public comment period during CON. When people do not raise the comments, I think sometimes the department does not, but I'd let the department speak for themselves.
And we heard his testimony. Thank you.
Thank you. So just a quick reminder, this is for clarifying questions today. Any other questions for Mr. Jeffrey? No, thank you.
Thank you.
I got thrown for a second there, sorry. Thank you for your testimony. Additional people in the room wish to testify in opposition, or are we in neither for nor against? Yes, thank you. I was a little confused about all this testimony. Are we still on the second bill?
You might be here in a while.
Okay. All righty.
Oh no, it's afternoon. 2 minutes after. Good afternoon. Chair Bailey, Chair Matheson, and esteemed members of the Committee on Health Coverage Insurance and Financial Services. My name is Angela Westhoff. I'm the President and CEO of the Maine Healthcare Association. We represent more than 200 nursing homes, assisted living, and residential care facilities. I'm pleased to testify neither for nor against on LD 2190. I too was a member of the commission. It was an honor to serve. I think with a compressed timeline, however, of just 5 meetings between October and December, we ran out of time to fully vet all concepts and proposals. And I would just note that some of the bills that resulted from the commission's work that you're going to hear today, the impact of some of that potential legislation could not only be profound on Maine's healthcare landscape, but also potentially dangerous with unintended consequences if not carefully and thoughtfully explored. I'm going to talk about some different sections that you haven't heard so far in this public hearing. Sections 1 and 2 of the bill, which define private equity company and real estate investment trusts. As written, these definitions are far too broad, and they unintentionally sweep in small local investors who have been essential partners in keeping Maine's nursing homes open. These are generally not large national firms. They are often Maine family-owned businesses who step up and provide funding for nursing homes because they are committed to ensuring access to long-term care for older and disabled adults in Maine. The committee's likely aware that Maine's long-term care sector has been in a fragile state. Since 2014, we've had over 50 facilities that have either closed their doors or converted to a lower acuity level of care. You've also heard that Maine care rates do not cover the full cost of providing this care, and we also have a workforce crisis that continues to strain operations. Banks are increasingly unwilling to lend to facilities with such instability in the sector. One nursing facility recently approached, 9 different banks just to refinance an existing mortgage. Local investor groups are game changers. They provide the capital needed for medical equipment upgrades, building improvements, and even new construction. And more importantly, Maine's Certificate of Need laws already prevent unchecked expansion. Maine's nursing homes are held to a principle called net neutrality. That means that any new project in the state cannot expand the existing number of nursing home beds. There either has to be enough funding in the Maine Care Nursing Home Funding Pool, or the legislature can act to provide additional funds, which they have not done in many years, and the current balance is $147,665. Might be enough to buy 1 bed. A project may also seek to reopen beds previously reserved through a process commonly known as bed banking, but it may not exceed 100 beds annually. These rules, the limited main care bed pool and strict caps on reopening bed banks ensures that no one, local or otherwise, can flood the state with new facilities. And in fact, these conditions actually make Maine unattractive to outside investors. I'm going to jump ahead to section 6 of the bill. You've heard a lot about affordability and accessibility. While those definitions also need to be defined, one thing that I would raise for your awareness is that the commission recommended creating a task force to assess long-term care demand in Maine and to determine the appropriate number of beds statewide. We are the oldest state in the nation. However, we have the fewest beds of any state in the Northeast per capita. We should be focused on increasing capacity, not creating new barriers. Finally, in section 9, we recommend establishing clear parameters for con analysis, reasonable costs to applicants, itemized preliminary estimates, and defined timelines, no more than 90 days for review and then 30 days for delivery of those results. Without those amendments, I fear the bill will have unintended consequences. Nursing homes are already struggling, and limiting access to capital will only accelerate closures. Thank you, and I'd be happy to answer any questions.
Thank you for your testimony. Any questions from committee members? Seeing none, thank you very
Thank you.
much. There are additional people in the room that like to testify neither for nor against this bill. And Christian is no longer. Okay. Good. Is there anybody in the room that would like to testify on this bill on any behalf? No? Great. Other questions or information that the committee would like for the work session? Seeing none, we can close the public hearing for LD 2190. There you go. Hand it over to you,
All
Sally.
right, thank you. We'll open the public hearing on LD 2197. An act to prohibit the sale and lease back of a healthcare entity's main campus to a real estate trust as recommended by the commission. And just for committee members and the audience to know, we are not planning on taking a break for lunch. So I, encourage you to do what you need to do to take care of yourself. You can go get lunch. You're certainly welcome to sit in the chair's office so that you can listen to the public hearing while you eat lunch. But we are not, given that it's already past noon and we've only gotten through 2 bills and we've got 6 more to go, we are not going to be taking a lunch break.
All right, just for an update, Senator Tipping is going to introduce the next bill, so you guys will get a break from me. Senator Bailey, Representative Matheson, members of the Health Coverage, Insurance, and Financial Services Committee. My name is Michelle Boyer, and I represent District 123, part of Cape Elizabeth. It is an honor to come before you today to support LD 2197, an act to prohibit the sale and leaseback of a healthcare entity's main campus to a real estate investment trust, as recommended by the Commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. During the Commission's work, we learned that the sale and leaseback of a healthcare entity's main campus is one of the ways a healthcare entity can be taken advantage of. A major focus of the Commission's work was examining the effects of private equity on the healthcare industry. We learned during a presentation by Dr. Song that the sale and leaseback of a healthcare entity's main campus is a tactic used by private equity firms. This tactic contributed to the significant financial difficulties and closures of several hospitals in Massachusetts and has also led to problems in other states. The sale and leaseback of a healthcare entity's main campus carries potential financial risk to a healthcare entity if it is not able to manage the debt payments required for such a transaction. Thank you for your time, and I'm happy to answer any questions.
Thank you. Questions from committee members? Seeing none, thank you very much. Anyone else in the room wishing to testify in favor of this bill?
Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. My name is Louise Secordell, and I am testifying on behalf of Maine All Care, an organization dedicated to universal health care for all Maine residents. We appreciate the committee's continued work following the commission's review and final report. We offer testimony in support of LD 2197. As you know, Maine's hospitals are under serious financial strain, and that makes them targets. Private equity firms promise a short-term infusion of cash, but their business model requires extracting that investment back out, along with substantial returns for investors. One of the most harmful mechanisms used in these transactions is the sale-leaseback arrangement, as you heard by Dr. Song. That is where, after acquiring a hospital, a PE owner often sells the hospital's land and buildings to a separate real estate entity, the real estate investment trust, as we've heard about, and then requires the hospital to lease that property back. That money from the sale goes to repay investors, pay down the loans, or support other expansion plans. It doesn't go to patient care. The hospital permanently loses ownership of its real estate and becomes obligated to make long-term rent payments. And so, as you've heard, this happened with the collapse of Steward Healthcare in Massachusetts. Under PE ownership, they sold their hospital property to Medical Properties Trust in such a transaction. It generated a lot of cash up front, saddled the hospitals with significant ongoing rent obligations. And then when operating margins tightened, those lease payments did not. So when Steward ultimately filed for bankruptcy in 2024, 2 hospitals in Massachusetts closed permanently. The state was forced to seize a third through eminent domain to keep it open. And of note, Massachusetts did not prohibit sale-leaseback arrangements until this had occurred. If private equity acquisition were prohibited outright, LD 2197 would not be necessary. However, if it's not banned, then Maine All Care strongly supports this bill. These sale-leaseback agreements are particularly harmful to hospitals and increase their risk of bankruptcy, as recent research shows. LD 2197 would prevent one of the most extractive practices associated with PE ownership and help protect Maine hospitals from further destabilization. So we urge for your support, and I'll note that many of our members and supporters have submitted written testimony for this bill and others for today. Thank you.
Okay, thank you. Questions from committee members, Representative Olson.
So question, in the Stewart case, what would have happened to them had they not had the buyout from the entity? Would they simply have closed, or where would they be today had the initial acquisition not taken place?
Can you clarify who you mean by they?
The hospital that Stewart bought.
The original hospitals back in 2010?
Yes.
I can make sure I get that information to you for the working session. Yeah.
Good. Other questions? Representative Flynn.
Thank you, Madam Chair. Thank you, Doctor. Are there any cases where a lease buyout has been successful?
Successful to whom?
To the community, with the hospital still open and it's vibrant and operating?
I can also get that information back to you.
Representative Harper.
Thank you, Madam Chair. Now I have to remember my question. Thank you for this testimony, by the way. It's very clear and straightforward, and I appreciate the example that you have given. And my question is, this is it. The law you mentioned here sees you in the bottom of your third paragraph, you talk about did not prohibit sale leaseback until after the Stewart catastrophe. Did they pass a law at that point?
That's correct, yeah.
I would love to see that.
Yeah, absolutely. I'll get it for you.
Provide that?
Yeah.
Okay, great. Thank you very much.
Okay, further questions? Seeing none, thank you very much.
Thank you.
Others in the room wishing to testify in favor of this bill?
Hello again, Senator Bailey, Representative Matheson, members of the committee. I'm once again Trevor Putnaki, representing the Healthcare Purchaser Alliance of Maine. I apologize for doing it this way, but I actually grouped a number of bills together in my testimony. As I mentioned before, I had the privilege of participating in the commission where we evaluated these bills. So I'm testifying specifically right now on 2197, 2198, and 2201. I think these bills really all together are sort of one piece in trying to get a handle on the really potentially significant risks of private equity moving into the healthcare system in Maine. Now, we have not seen a large proliferation of private equity in Maine to date, but nationally it has been picking up pace and picking up pace very quickly. In 2025, PE firms executed approximately 445 healthcare buyouts, yielding the second highest annual total on record. We had the pleasure of hearing from probably the foremost expert in the country on private equity in healthcare during the commission, Dr. Zuru Song, who's a Harvard researcher, who walked us through a whole bunch of his studies on what happens when private equity gets involved in the delivery of healthcare. He basically said in PE's pursuit of profit, acquired entities experience increased prices, increased incidence of adverse health outcomes, and increased physician burnout. And as PE firms leverage complex financial tools like debt financing, acquired entities run the risk of being saddled with crippling debt that can lead to closures and communities having to pick up the pieces. I believe the prior individual mentioned the debacle with Steward Healthcare in Massachusetts. After they filed for Chapter 11 bankruptcy in 2024, they carried over $9 billion in liabilities. And as of May 2025, 2 hospitals had suspended activities or suspended services and 5 had closed. And the fate of the other hospitals within that system is really tenuous right now. So in Maine, where access and affordability challenges are already really significant problems, I don't think we can afford to risk the potential for the negative outcomes that are correlated with PE investment. While I will not pretend to be an expert on private equity, I believe that preventing sale and leaseback arrangements, requiring minimum debt to equity ratios, and undertaking robust reviews of proposed PE acquisitions are really common sense proposals to guard against what has become a clear risk to the health of our delivery system. Thank you very much. Happy to answer any questions, noting that I am not an expert on PE, but I'll do my best.
Representative Olson.
I guess it's kind of carrying on with the question I asked before. What other entities are in there other than the PEs to try and work on some of these bailouts? So if you have a facility that is distressed, ready to go into bankruptcy, and the PE is its only option, absent that, where are they going to be?
Well, I think that which bill is it? The 2201 tries to get at that. It's not saying that private equity cannot step in to rescue a distressed hospital or provider in the market. It's just saying that we want some level of oversight to make sure that they're not using, debt equity financing to leverage the institution and put them in an even worse shape while they asset strip them and then take their money and leave the state, right? I think that sort of oversight would allow some protections and some potentially caveats to the acquisition of that provider so that you're avoiding the worst possible outcomes. So I'm not here to say that we should have no private equity in healthcare at all. I don't think that's the case. I mean, we have some private equity. Some private equity in our healthcare system has been positive. I mean, we see a lot of investment in urgent cares and infusion clinics that have offered really affordable options to Mainers and created some level of competition within the healthcare market. We just want to avoid where these big private equity firms come in, buy a distressed asset, sell off everything, and then exit the deal, leaving them in a very tenuous position or having to close down.
Further questions? Seeing none, thank you very much.
Great, thank you.
Anyone else in the room wishing to testify in favor of this bill?
All right. Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. I'm Kate Endy, and I'm the Policy Director for Consumers for Affordable Healthcare. Thank you for the opportunity to provide this testimony in support of LD 2197. As you've already heard, this is a recommendation of the, I'll just call it the Oversight Task Force, which I was privileged to have the opportunity to be a member of. This bill would prohibit the sale and leaseback of healthcare entities' main campus to a real estate investment trust. As you've heard, sale and leaseback arrangements can shift ownership of critical facilities away from healthcare providers to outside investors whose primary goals may not align with community health needs. This bill would ensure that the core campus of a healthcare provider, often the hub of acute, emergency, or specialty services, remains under the control of entities whose mission is patient care and community well-being. As you've heard, we only need to look as close to Massachusetts to see an example of how private equity acquisition of a healthcare system and the subsequent harvesting of its assets, including the sale and leaseback of hospital campuses, failed dramatically and worsened access for patients. In 2010, a financially distressed hospital system in Massachusetts was purchased and rebranded as Steward. After an initial monitoring period, there was a $1.25 billion sale leaseback agreement with a publicly traded firm. So the hospitals now had millions of dollars of rent each year for property they previously owned. This deal contributed to the downfall of the healthcare system by creating an unsustainable debt burden for the hospitals, while shareholders extracted millions of dollars in profit. Leaseback arrangements introduce additional financial risk and instability for healthcare facilities. And by prohibiting the sale and leaseback, this bill will help to safeguard the continuity of care and long-term service availability that me and families depend on. So for these reasons, we support this bill and happy to answer any questions.
Okay, thank you. Questions from committee members, Representative Arford.
Thank you, Madam Chair, and thank you for your testimony. This is the first we've discussed it previously in terms of the commission's report, but sale leaseback agreements, can you tell me, we're talking about what happens when it happens, when they actually do a sale, when a hospital does this, sells off its property and then rents it, and how dangerous and destructive that can be. But after they go bankrupt, which happened here, then what happens? I mean, the hospital is no longer.
So I believe in Massachusetts, in that example, I believe as Mr. Putnaki referenced, there were some hospitals that closed and I believe some that were absorbed by other systems.
So if the hospital closed, it was just empty real estate. It wasn't resold to another entity, which then assumed the rental arrangement?
I mean, I haven't followed up to see what was done with the physical space, but presumably it would be empty if they shut down.
Yeah,
until another business acquired it.
Thank you.
Any other questions? Representative Flynn.
Thank you, Madam Chair. Probably in the last year, I've heard a lot about this Massachusetts debacle of the PE acquisition of the hospital there. My question remains, are there any cases where this has been successful?
I'm not saying there's not. I'm not familiar with many success cases. So I'm not saying they don't exist, but I would say in general, I don't believe that the fundamental goals of private equity align well with providing high quality, sustainable healthcare. But there could be instances where some investment could be positive. Happy to look into that more.
My only concern is before we go so far to prohibit it from happening, based upon what happened in Massachusetts, I think we owe it to the process to see if there are any that have been successful, and then what guardrails were used on the success stories. Thank you.
Further questions? No, thank you very much.
Thank you.
Anyone else in the room wishing to testify in favor of this bill? All right, I think we have one person online. And if you could move over, Marie. Good afternoon, welcome.
Good afternoon. Can you hear me?
Yes, we can.
Wonderful. Thank you. Good afternoon, Chairs Matheson and Bailey, members of the committee. I'm grateful to be here. My name is Marie Folatar, and I am from South Portland with Disability Voters of Maine and a proud member of Maine All Care. I am neither for nor against LD 2201 as currently written because I do not feel it goes far enough to protect Maine's hospitals and community. The evidence is abundantly clear that hospitals acquired by REIT trusts faced a 5.7-fold higher risk of closure or bankruptcy. The federal budget report, Health and Human Services report, countless researchers have shown that private equity acquisitions are linked to higher patient costs, staffing reductions, and worse quality outcomes, even leading to patients being removed out of hospitals so their numbers wouldn't count as deaths. Private equity firms are obligated to maximize investor returns, its profit. Their investments sort of guidelines are about 3 to 7 years. That's a short-term investment in our state's long-term infrastructure. And we're facing the consequences of that. And I'm a little concerned that people are not as aware of who coming before the committee is actually representing private equity and REIT, and the need to transparently identify this. Because, for example, Genesis Healthcare is tied to Sandy Hook, which is then tied to Genesis Healthcare of Maine LLC, which is Genesis itself, and it gets confusing quite fast when you try to understand who owns what. And the name down the corner of your nursing home, is it a different thing than Genesis because it's a different name? And what are you learning about? When we look at the Intermed development that's currently under process in the Scarborough area, it's tied to Remedy Medical Properties, Kane Anderson Real Estate, Welltower Public REIT, Wall Street Financing, Citigroup, JP Morgan, Goldman Sachs, and everything. And that's fairly precarious. This bill does not cover that. It would cover hospitals. But I'm share this to say that we already have questions. We have an unstable nursing home system that is literally built on an original REIT. That is literally what happened, is that Sandy River was the nursing home. They sold it to Genesis, and they sold it to remain the REIT. And here we are. And we need to be asking questions about this. It is your obligation too. The commission concluded unanimously that we must prevent leaseback of a hospital's main campus. If revenue dips, rent does not. Workforce shortages increases. The community is impacted, but rent does not decrease. We know it goes up. Medicaid payments delayed, rent still due. So we know that we can't afford a single closure. We have states all across the country working on legislation around this. We have federal evaluations. We have independent research evaluations. And this is Wall Street and speculators playing with our healthcare infrastructure for profit.
If you could finish up.
Survive. And thank you. I just, it's a moral boundary, and Maine should either prioritize life-saving capacity or not.
Okay, thank you. Questions from committee members? Not seeing any. Thank you for joining us. And we don't have anyone else online, right? Edna, for this bill. Thank you. Anyone in the room wishing to testify in opposition to this bill? Anyone wishing to testify neither for nor against this bill?
Senator Bailey, Representative Matheson, members of the committee. My name is Jeff Austin here on behalf of the Maine Hospital Association, testifying neither for nor against. You got an earful about private equity. The bill is not restricted to private equity. Our suggestion would be, if you want to review private equity related transactions, put that in the bill. This is overbroad compared to all the testimony you've heard, and
overbroad, we believe, compared to what the commission heard. So if you want to restrict it to private equity transactions, we're neither for nor against. A couple of issues. It's a very short bill and it has 6 definitions in it, but not one for sale leaseback. So we asked our members about this and they actually had a hard time answering the question. And they're like, well, financing can be complicated. We don't think we do this, but there are some like build leasebacks with a contractor that you might do. And they're like, well, I don't know if that qualifies because it's not defined. So it's odd when you have 6 definitions and the one action that's prohibited is not defined. You might want to look at doing that. Again, we're neither for nor against as long as you restrict this to private equity and those players, because the commission heard no testimony about sale leasebacks in the nonprofit hospital. I will add a plug-in for the prior bill. I don't know that you need to ban sale leasebacks as much as you might need to get an expert in to see if this particular sale leaseback arrangement is unduly risky, which some are, or is not unduly risky. And then finally, this hasn't been said. I don't know how much everyone's aware of this. I'm not worried about this at all in Maine. All the hospitals in Maine, which is what this applies to, our main campuses, the hospitals in Maine are nonprofit. As such, we are public charities. As such, we are subject to review by the Attorney General for no private inurement for public charities. So if we were to sell our main campus to a private equity firm, that would go up to the AG's office to see where the money was going. They would tear that deal apart because as a function of their public charity review, we can't sell off our assets to a for-profit entity for private inurement. So I don't think this is a huge risk in Maine because all our hospitals are nonprofit and the AG's office, I think, would tear the deal apart. But I don't oppose you restricting it to private equity because I don't think they're coming for us. So with that, I'd be happy to take any questions.
Questions from committee members? Seeing none, thank you very much.
Thank you.
Anyone else wishing to testify, neither for nor against? Great. Anyone wishing to testify in any way on this bill before we close the public hearing? Any requests for Colleen? Is Colleen there? She's not.
So no requests.
Well, I did have a question for her, but I guess I'll ask her later. Yes, thank you. So we will close the public hearing on LD 2197 and open the public hearing on LD 2198, an act to implement certain recommendations related to the ratio of debt to equity in transactions involving healthcare entities from the commission. And this is going to be introduced by Senator Tipping. Welcome.
Thank you for having me. Senator Bailey, Representative Matheson, honorable members of the Health Coverage Insurance and Financial Services Committee. My name is Mike Tipping. I represent Senate District 8 in Penobscot County. And I'm glad to have the opportunity to testify in favor of LD 2198, an act to implement certain recommendations related to the ratio of debt to equity in transactions involving healthcare entities from the commission as named. Also, thank you to Representative Boyer for letting me take a couple of these. You've already heard our report back on the findings and recommendations of the commission, and so I won't go into detail on the composition, mission, or process of that body. I will say, however, that this relatively short piece of legislation could offer one of the most significant protections for public health arising out of the work of the commission. This bill prevents the purchase of a healthcare provider, a healthcare facility, or a provider organization with a debt to equity ratio of more than 50%. This would prevent one of the most pernicious and harmful practices of private equity firms and similar actors, where a healthcare entity is loaded up with debt as part of its purchase, often with a ratio of 70 to 80% debt. This quickly exports the value of the hospital or other healthcare entity to the shareholders of the firm, and it leaves the healthcare provider and the patients it serves in a precarious financial position. We've seen the devastating results of these transactions in states across the country, and you've heard about them today. And we have the opportunity now to build on the work of this committee began by passing the temporary private equity moratorium and more permanently safeguard public health in Maine. The commission arrived at this proposal after hearing testimony and presentations from the public, from experts on private healthcare transactions, and from legislators in other states. The idea of targeting harmful practices of private equity rather than definitional restrictions on the firms themselves was first proposed as an approach by the Maine Hospital Association. The specific mechanism of addressing debt to equity ratios and the proportion of 50% was recommended by Professor Song of Harvard Medical School, one of the nation's leading experts in private equity and healthcare. As he said, in this case, we're targeting not a particular type of owner, and we're not labeling anyone, but by limiting healthcare transactions to 50-50 debt, that would immediately put less risk on the acquired entity, and it would immediately make less of their belongings go into the deal as collateral. One aspect of this bill the commission may want to give some additional thought to is the definition of healthcare entity. This definition appears to be the same as that used in LD 1972, and it excludes nursing homes and nursing facilities. Given the threats that those facilities face, the committee may want to use a different, more expansive definition of healthcare entity like those used elsewhere in Title 22. I would also say, just responding to some of the questions that we've heard, the research across the country and over time shows that those healthcare entities that are purchased and targeted by private equity and other acquisition, they're not actually usually doing worse than other entities. In fact, they're doing slightly better. And it is only after their acquisition and some of these practices are put into place that we see that downward trend. So I think that is the broad concern there, and the idea behind this and some of the other legislation here is exactly, I think, what one of the members of the committee was just saying there about, are there good examples of how this can be done? And I think, there's certainly the possibility of that. And that's why the commission wanted to target not the actors, but the practices. Some of those practices that had no, legitimate supportive process there to help healthcare entities. In this case, simply extracting any equity that is left in the healthcare entity and moving that to the shareholders.
Okay, questions from committee members? Not seeing any. Oh, Representative Arkford.
Thank you, Madam Chair. I continue to be very interested in examples in our state where a private equity buyout or transaction has had a positive result financially and community-wide at any place or statewide. And I don't know if you have any examples of that or are aware of any example. If you do, I would love to hear about it.
I don't know if I have like glowingly positive examples. I will say that there are kind of different models where private equity has been involved. Some where they want to, extract equity as quickly as possible, and that's where we've seen some of these quick closures. And there's others where they want to, operate the healthcare entity over a more long-term basis and kind of extract rents to pay for management services, for real estate trusts and other things like that, where, the services to the community may continue, maybe in a decreased way, but a lot of the wealth of the entity will be transferred out. So those could continue for a long time, and if they that is the point of that kind of arrangement. And I would say on this, private equity is not alone the target here. This is not trying to define certain actors. This one is looking specifically at this practice where, to use the metaphor as we have before of, rescuing a sinking ship, this is putting a hole, in the side of the boat. So no matter who it is, no matter what entity you're trying to rescue, this is never a good idea.
Thank you. Any other questions? Seeing none, thank you for presenting this. Is there anyone in the room wishing to testify in favor of this bill? Anyone? Oh, coming up.
Good afternoon, Senator Bailey, Representative Matheson. I am still Kate Endy with Consumers for and members of the committee. Sorry, I'm still Kate Endy, Policy Director for Consumers for Affordable Healthcare. Thank you for the opportunity to provide this testimony. We strongly support this bill, which would implement an important recommendation from the Commission, the Oversight Commission. This bill aims to establish clear and prudent standards regarding the ratio of debt to equity in transactions involving healthcare entities. Transactions involving high levels of debt relative to equity introduce financial instability into organizations that provide healthcare services. Excessive debt burdens can limit facilities' ability to invest in patient care, sustain operations, and could lead to reductions in services or higher cost to patients. By implementing guidance on acceptable ratios of debt to equity, this bill helps ensure that changes in ownership do not worsen access to healthcare delivery and that transactions align with long-term community health needs rather than short-term financial gains. Better financial protection practices lead to more predictable, reliable care for patients. And for these reasons, we urge you to support this bill.
Thank you. Questions from committee members? Representative Olson.
Thank you. Do we have a handle on what the debt to equity is for the existing facilities right now?
I do not know that off the top of my head, no, but happy to do some research.
So where my concern is there, you could have a facility already that's exceeding the 50%. And this is coming in to try and help them out. So automatically it precludes them from getting help.
Further questions? Seeing none, thank you.
Thank you.
Anyone else wishing to testify in favor of this bill? Anyone wishing to testify in opposition to this bill? Anyone wishing to testify neither for nor against this bill?
Senator Bailey, Representative Matheson, members of the committee. My name is Jeff Austin. I'm here on behalf of the Maine Hospital Association, essentially to provide the same testimony I did on the last bill, which is the bill is not restricted to private equity. It covers any transaction. Again, debt to equity is not defined. I don't know if there's a definition somewhere in Maine statute. So what they're counting as debt, what they're counting as equity is a little unclear. We don't have debt to equity ratios for our members. But the second page of my testimony is equity financing ratios that MHDO does track for our members. It is not the exact someone explained math to me, so I will try to explain it to you. What I was told is this is not the mathematical inverse of debt to equity. But for purposes of this bill, it's close enough. I don't know if that's true. So we don't have debt to equity ratios for our members, but we do have equity financing ratios, which will give you directionally where we are. So everybody below 50% here does not have would run afoul of this bill. Everybody below 50%, potentially, I should say, will run afoul of this bill. They are financing more with debt than they are with equity. So we are very wary of overnight being barred, as you can see at the last line of this bill, from entering into any transaction of any kind because we have debt to equity ratios that exceed 50%. So again, nonprofit hospitals were not discussed. Transactions in Maine were not discussed. The entire context of this conversation was private equity. And we would encourage you to limit the bill to those transactions and not our members currently, or else we think we may be in big trouble if this passes as is. With that, I'd be happy to take any questions.
Questions from committee members?
I mean, it's not defined. I can't give you a clear answer. But what MHDO does track is equity financing. How much of your financing is based on your equity? And we're low, as you can imagine. To build up equity as a nonprofit, you got to run surpluses and keep them, which we don't really do. we lose money, or if we barely break money, we're not accumulating a lot of equity. This whole concept is a little weird in the nonprofit world anyway. I mean, the equity is essentially in our institutions held by the Attorney General in trust for the people of Maine. So the whole concept of the equity is a little weird in the nonprofit world, but to the extent it is measured, we're low. We don't have a lot of equity. We have a lot of debt. We're one of the most indebted hospital states in the country.
Any other questions? Thank you.
Thank you.
Anyone else wishing to testify neither for nor against this bill?
Thank you, Senator Bailey, Representative Matheson, and members of the committee. My name is Ann Robinson. I'm with Pierce Satwood, and I'm here today on behalf of Spectrum Healthcare Partners, which is a physician-owned multi-specialty practice group that provides practices throughout most of Maine. I just kind of want to put maybe a finer point on the points that Jeff made up, because he alluded to certain terms not being defined. And, we are neither for nor against, so long as some of these definitions are some of the terms are defined. Debt is not defined. And I think I heard Senator Tipping say, private equity isn't a loan. Well, as written, without a definition of debt, this could include a loan. It could include, for example, with Spectrum, where it's physician owned, even if shareholders finance something, but through a shareholder loan, that would be covered. Transaction isn't defined. So, I think most of the testimony is about, major transactions and purchases, but in fact, not even transaction is not defined. So this is really broad. So it's not entirely clear to us, how this would affect a lot of different kinds of business transactions. And so we just ask that those terms be clarified. Thank you.
Okay. Questions from committee members? Are you aware, and this might be more a question for Colleen, of any other states that have any sort of restriction like this that is tied to the debt equity ratio?
I am not.
Healthcare.
I haven't done that research, honestly. So,
Any other questions? Seeing none.
Thank you.
Anyone else wishing to testify neither for nor against this bill? Or in any way on this bill before we close the public hearing? And request for Colleen, Representative Olson.
Yeah, I guess, and maybe it's, we can get some information from the doctor that, Dr. Song, that where his definitions were on debt to equity and whatnot, because obviously he's looked at it from that. So when he did his analysis, what he was factoring in his debt, what he was factoring in his equity, so that we can kind of get a handle on where we are when we evaluate it against the current operating hospitals and whatnot.
Okay. And again, Colleen, just if you could find out if there were any other states that have done something similar. Appreciate that. Representative Chimino, do you have your hand up, or just now you're just holding your pen? Okay. It's okay. No worries. All right, so we will close the public hearing on LD 2098, and I'll move it back to my co-chair.
That was so quick.
Let it be known that my two bills took less than an hour.
Help me out, guys. Okay, we're opening up the public hearing for LD 2199, and I believe Representative Boyer is going to present this, an act to prohibit interference with the professional judgment and clinical decisions of licensed healthcare professionals as recommended by the commission. Thank you.
Hey, Senator Bailey, Representative Matheson, and dwindling members of the Health Coverage Insurance and Financial Services Committee. My name is Michelle Boyer, and I represent District 123, part of Cape Elizabeth. I'm honored to come before you today to support LD 2199, an act to prohibit interference with the professional judgment and clinical decisions of licensed healthcare professionals, as recommended by the Commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. During the Commission's work, we discussed the interference with professional judgment and clinical decisions of healthcare professionals. The majority of the Commission members were concerned about the potential risks to the professional judgment or clinical decision of healthcare professionals in Maine if private equity companies or management services organizations establish management practices or policies that may have a negative impact on the ability of a licensed healthcare professional to practice independently and deliver patient care. Several other states have introduced legislation on this topic, including Oregon, California, Massachusetts, and Connecticut. In addition, there is model legislation available around this topic. Thank you for your time, and I'm happy to answer any questions.
Thank you, Representative. Questions from committee members? Seeing none, thank you for your
Thank you.
testimony. Is there anybody in the room that'd like to testify in favor of this bill? Do we have anybody online for 2199? We don't, right? In favor? Okay. Is there anybody in the room that'd like to testify in opposition to this bill? Just remember, you're on a time clock here because
I
I'm
got
trying to beat
18 minutes that I
Senator
used this
Bailey's
morning, right?
timing here.
Okay, I'll make it fast.
Thank you
Yeah.
and welcome.
And Representative Olson, this is what you've been waiting for. Every time I don't stand up and testify on something, you know. Good afternoon, Representative Matheson, members of the committee. My name is Dan Demerit. I'm the Executive Director of the Maine Association of Health Plans. Thank you for your work today. We're speaking in opposition to LD 2199 as drafted because the legislation may inadvertently interfere with utilization management tools, including prior authorization and post-payment review that public and private payers health plans use to ensure that patients are getting medically necessary and affordable health care. As has been repeated several times today, the commission work really focused on private equity and MSO practices and policies. Utilization management was not a topic of those discussions, but we want to call this language out for your information. Utilization we're asking for an exemption for utilization review as defined in 24A, section 4304, be added to the bill if the committee is interested in advancing it. Utilization management. There are several pieces of the bill in section 1730B, number 2, that could be read as including coverage decisions that are made through the utilization review process, including whether a treatment or service is medically necessary. So if the committee does want to advance this legislation, we urge it to include language exempting that this section has nothing to do or it was not intended to limit utilization management as outlined in the Maine Insurance Code. And we would share, because we still have time left, that health plan utilization review does not undermine professional independence or judgment. It decides if something will be covered. The difference is, utilization review does not threaten the employment of the providing healthcare professional, doesn't undermine their independent practice authority, nor does it prohibit a provider from rendering those services. It's just a question of whether it's a covered service, it's medically necessary, and will be covered by the plan. We'd also share that utilization members, there are several appeals opportunities of a utilization management decision reached by a health plan, including peer-to-peer review, opportunities for member appeals, and opportunities for independent review organizations to take a look at a decision. So with that in mind, and with time still left to go and to give back to Representative Matheson, I would ask to include this exemption if the bill moves forward and be happy to answer any questions.
Thank you, Mr. Demerit. Questions from committee members?
Thank you.
Thank you for your time. There are additional people in the room who'd like to testify in opposition to this bill. you. Welcome.
Good afternoon, Senator Bailey, Representative Matheson, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Richard Lawrence. I'm a healthcare financial analyst with Division of Licensing and Certification. I'm here to testify on behalf of Bill Monteo, the Director of Division of Licensing and Certification, in opposition to LD 2199. Because of the broad language in this bill, appropriate interventions into patient care are not delineated from profit-driven interventions into care. The intent of this bill was to prohibit healthcare business corporations and entities such as private equity corporations and real estate trust organizations from impeding a physician's clinical decision-making. The bill prohibits interference with the professional judgment or clinical decisions of licensed healthcare professionals as it relates to the amount of time spent with patients, discharge decisions, and decisions around appropriate diagnostic tests, among other things. We understand that the intent of the bill is to keep business entities from limiting a physician's ability to order expensive diagnostic tests that they feel are necessary and/or to reduce time spent with patients to increase the profitability of providing care. We strongly believe that providers and patients should be able to work together to design the best care plan that works for the patient. However, the bill is written may also preclude hospital administration from directing a physician to change their plans of care, even if the plan of care is not consistent with national standards or regulatory requirements and safety policy requirements. While the department agrees with the intent that the physician should order diagnostic tests, medication, and treatments based on the needs of the patient and his or her clinical judgment, we are opposed to the bill as written, as it is too broad in scope. For example, an exhausted physician may inadvertently order the wrong concentration of a medication that, if given, could result in serious harm to the patient. The standard practice for a professional nurse requires that they interfere with the physician's clinical decision and advise the physician that they question the clinical decision's appropriateness to clarify the order and advocate for the safety and well-being of the patient. The department recommends the bill be voted as ought not to pass and would encourage more input from the boards of nursing, medicine, and osteopathic medicine to better outline the implementation of the commission's recommendation. Thank you.
Representative Mastracchio.
Thank you, Madam Chair. So you're not opposed to a discussion around this, that you just think that there hasn't been enough discussion and enough input from interested parties? Oh, look who's here.
Come to Bill.
There you go.
Will the
How
real
is it?
Bill Monteo please stand up? Representative, no, we just feel that the bill as written is a little too broad.
All right, thank you. I appreciate that. I was looking at the actual recommendation and I saw that it says a majority, but it was it was not a, like, it
I
was
think-
just by one vote and.
Yeah, I think we agree with the intent of the bill, but the concern, and we have seen this, I have seen this, where a physician with good intentions is doing something in the patient's best interest, but the processes that they used violated a regulatory standard and got the hospital in difficulties. Had there been more discussion, they could have accomplished that. So this is why we think this is a little too broad and needs a little more thought and input. But we agree with the concept.
So there's a way to do it? Maybe?
I think there is a way to do it, but it's gonna require a lot more input.
Okay, thank you.
Yeah.
Additional questions? Seeing none, thank you. Welcome.
Hi, Representative Matheson, members of the committee. My name is Sarah Calder with Maine Health, and I'm here to testify in opposition to LD 2199. Maine Health fully supports protecting the professional judgment and clinical autonomy of licensed healthcare professionals, but there also must be systems in place to ensure accountability, quality of oversight, and appropriate clinical decision-making. As you heard from Director Monteo, we have legal and ethical obligations to monitor performance, track outcomes, and ensures patients receive timely and appropriate care. And as others have said, we believe that LD 2199 is overly broad and could unintentionally undermine those responsibilities. As just a few examples from the bill prohibits controlling the amount of time spent with a patient or the number of patients that can be seen in a given time. Today, we track metrics like emergency department door to provider time and time to transfer to an inpatient bed. We set expectations around timeliness because delays can result in patient harm. If a hospital monitors these metrics and provides feedback to improve performance and reduce patient boarding, would that now be considered prohibited interference? The bill also prohibits controlling where a patient should be placed upon discharge. Maine has lost 40% of its nursing facility beds since 2014. At any given time, there are 100 patients within the Maine Health system who are waiting for residential placement. Last year, we were forced to send over 100 patients out of state because there were no beds available in Maine. So a provider may agree with the family's preferred placement, but if no bed exists, the patient may be placed in another facility or placed out of state. Would that be considered interference? As Dan mentioned, this bill raises questions about diagnostic testing. The greatest tension in this space is not between hospitals and providers, but between providers and insurers that delay or deny coverage for these tests. While we don't prevent our providers from ordering appropriate tests, we must help navigate payer requirements to protect both the patient and the organization from financial harm. Could that be viewed as interference? Another issue that's raised in the bill is that while some advanced practice providers have independent practice authority under state law, Maine Health requires physician supervision or collaborative oversight to ensure coordinated, high-quality care. Would that structure now be prohibited? And so I think you've heard it today many times, but we believe that the bill as drafted is too broad and would urge you to vote ought not to pass. It was difficult to hear back there. I tried to read the closed caption. I think maybe Oregon was mentioned as a model state. It's my understanding, but I will double check that hospitals were exempt from that bill. So thank you. Happy to answer any questions.
Questions from committee members? Seeing none, thank you for your testimony. Are there additional people in the room that like to testify in opposition to this bill? Thank you.
Good afternoon, Representative Matheson, committee members. My name is Lisa Harvey McPherson, and I'm here to testify in opposition to this bill. I want to reflect on the commission's discussion in this policy space from the perspective of concerns around private equity. I respond to this bill from the perspective of a not-for-profit employer of healthcare professionals in Maine. And so the bill states that a healthcare entity may not directly interfere with, control, or otherwise direct professional judgment or clinical decision-making of a licensed healthcare professional with independent practice authority. We believe that this bill will have harmful impact on our patients and fraudulent impact on healthcare. The bill specifically talks about independence in admitting patients to the hospital, observation, and discharge. If a provider compels admission of a patient that is not allowed by regulation, not allowed by payers, then that patient is placed in an inpatient bed. And if that provider compels billing for that service with full knowledge it's not a covered service, that's fraud. If the provider compels admission to the hospital with full knowledge that it's not a covered service by the insurance, we need to notify that patient that they will be fully financially responsible for that inpatient stay. That's an unnecessary financial burden for a situation in which we knew in advance that inpatient stay would not be covered. The bill also prohibits a healthcare entity from interfering with independent professional judgment, but we may have situations of unsafe care, direct harm to patients, and fraudulent clinical documentation, or any professional practice or decision that deviates from evidence-based care and compliant healthcare business practices, and we legally are prohibited from intervening. The bill also states that the employer is prohibited from actions that are adverse, including coercion, retaliation, excessive pressure. The very real outcome of this legislation for a not-for-profit employer is we would need to severely curtail our employment of healthcare professionals with independent decision and judgment-making authority, because we cannot have providers that are not safe and not compliant. And this will have a devastating impact on primary care and rural care. As we all know, and we discussed many times, access in rural Maine is because of employers such as hospitals and health centers and others providing access to challenged populations. So with that, I am running out of time and I welcome any questions that you have.
Thank you. Questions from committee members? Seeing none, thank you for your
Thank you.
testimony. There are additional people who would like to testify in opposition to this bill.
Good afternoon. Again, Representative Matheson. I don't think I see Senator Bailey.
She's eating.
Andy McLean, again, speaking in opposition to the bill on behalf of the Maine Medical Association, the Maine Osteopathic Association. My colleague, Chris Ossenford, is signing me in, so I appreciate that. At this point in the testimony, I think, joining the chorus of concern about the potential for unintended consequences here. And again, this doesn't have anything specifically to do with private equity financing. Physicians today, the only way a physician today is going to have absolute autonomy in clinical decision-making is if they hang out a shingle and open their own practice. Otherwise, every healthcare organization has aspects of clinical supervision, credentialing standards, and the like that are, as you've heard, I think are perfectly appropriate and in support of overall good care. What may be a little different in my written testimony, I have pointed out there are several relevant provisions of the Code of Medical Ethics that I would advise a physician to assert if necessary in defending clinical judgment in the workplace. I would be happy to answer any questions.
Thank you very much. Questions from committee members? Seeing none,
Thanks.
thank you for your testimony. There are additional people who would like to testify in opposition. Yeah, I always have the ones.
It's Andy, and I didn't sign myself in. Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenford. I'm the Director of Government Relations for Anthem Blue Cross and Blue Shield. And I appear before you to testify in opposition to LD 2199. Like others, we do not have objections to the concept, but concerns with the drafting of the legislation, or the breadth, I should say, of the language contained in the bill. Not all management services organizations are bad. And so we would encourage the committee to consider including a definition of management service organization and allowing some functions of those. I think one of the suggestions I received when folks reviewed the bill is that we're really looking at the concept of inappropriately interfering with the exercise of a practitioner's judgment. So that would be something for the committee's consideration, is to narrow it to try to address those situations where
to permit those situations where it is appropriate to intervene. And we would echo the comments of Mr. Demerit, clarifying that it's not intended to limit the ability of health insurance carriers to use utilization management tools as well. So with that, I'd be happy to answer any questions. We'll, of course, be present at your work session as well.
Senator Bailey.
Thank you, Madam Chair. A really simple question. So looking at the report, it looks like this recommendation, the vote was 7-6, but your name appears on both sides. Did you vote?
I noticed
twice?
that.
Oh, which side?
I
were
believe
you
I was
on?
in the opposition, but I'd have to go back and look at the video recordings. But I believe I was in opposition. I did notice that, and I was just struggling to remember. I was hoping you wouldn't ask. I'm
Sorry.
I'm elusive.
Thank you.
Neither for nor against.
Right. We get the concept.
Yeah. Additional questions? Seeing none, thank you for your testimony. Your additional people like to testify in opposition? I can't remember. Honestly, yeah, I think one person.
Good afternoon, Senator Bailey, Representative Matheson. My name's Ellie Espling. I'm with Sarah Public Affairs. I'm going to be sharing testimony from Lori Dwyer, who is the president and CEO of Penobscot Community Healthcare. PCHC is the largest of Maine's 20 federally qualified health centers, serving approximately 55,000 patients, with locations in Penobscot, Waldo, and Somerset counties. I'm just going to abbreviate her testimony. You'll have it in front of you. PCHC appreciates and shares the intent behind LD 2199, ensuring that licensed healthcare professionals can exercise independent clinical judgment free from inappropriate interference. However, as drafted, this bill is overly broad, ambiguous, and could unintentionally undermine the ability of healthcare organizations like PCHC to operate safely, efficiently, and in compliance with state and federal requirements. First, the bill's use of the term person is extraordinarily broad and unworkable. Subsection 2 prohibits any person from directly or indirectly interfering with, controlling, or otherwise directing the professional judgment of clinical decision of a licensed healthcare professional. And as written, a person could include a licensing board, an accrediting body, an educational institution, and so on and so forth. Second, the bill does not account for situations where clinical decisions fail to meet standards of care, ethical or legal requirements, or evidence-based practice. Third, the bill could be interpreted to prohibit standard employment expectations that are essential to patient access. Fourth, the bill could interfere with legal and regulatory compliance and anti-fraud, waste, and abuse obligations. The bill relies on undefined and subjective terms such as excessive pressure. In short, LD 2199 attempts to address a legitimate concern, but does so in a way that could produce unintended and harmful consequences for patient access, organizational accountability, financial sustainability, and legal compliance, particularly for community-based providers serving vulnerable populations. We would welcome the opportunity to work with the committee to develop a more balanced approach that protects both clinical independence and the operational structures required to deliver care safely and efficiently to the people of Maine. And I'm happy to try to answer any questions you may have.
Questions from committee members? Just had one. So thank you for offering to help the committee develop a balanced approach that protects both. I have heard from everybody who's opposed this that they appreciate and share the intent behind it. So I will take you up on that suggestion because I would like to see something move forward with the intent of this bill without it impacting all of the opposition to the bill. So I take you up on that.
Happy to share.
Thank you.
Thank you.
Thank you for your time. Any additional people like to testify in opposition? Is there anybody that would like to testify neither for nor against this bill? We don't have anybody online, right? Okay. Are there any requests from the committee members for Colleen for the work session? Seeing none, we'll close the public hearing for 2199 and we'll open up the public hearing for 2200. I believe that Senator Tipping is introducing this. It is an act to prohibit non-complete clauses for healthcare professionals as recommended by the commission. Welcome, Senator Tipping.
Thank you. Thank you, Senator Bailey, Representative Matheson, honorable members of the Health Coverage Insurance and Financial Services Committee. I remain Mike Tipping. Glad to have the opportunity to testify in favor of LD 2200, an act to prohibit non-compete clauses for healthcare professionals as recommended by the Commission. This is a somewhat different proposal from some of the other legislation before you recommended by the Commission. Rather than addressing healthcare transactions and agreements between entities, this addresses transactions and contracts between those entities and their employees. It is, however, meant to address some of the same concerns about healthcare affordability and access that we've been hearing all day and for a long time. Non-compete clauses prevent healthcare providers from switching jobs and going where they may be more needed. In some cases, they have geographic restrictions that could be particularly detrimental to rural Maine. That's why a majority of the commission, including members representing both hospitals and healthcare providers, supported recommending this legislation. I'd also note that there is testimony in your folders from Bill Monteo at DHHS in favor of this bill. I know he's been represented by a revolving cast this morning, but I believe he's now there in person. But I was glad to see that stamp of approval in particular, as the administration previously opposed and the governor vetoed similar legislation that would have outlawed non-compete clauses for all Maine workers in the 131st legislature. But the legislature then came back, passed, and the governor allowed a bill prohibiting non-compete clauses for veterinarians to go into effect last year, given some very similar concerns about healthcare availability for animals in Maine. So I would note that finally, given that the committee has decided to hold the public hearing on this bill here, I would support the committee working on and voting on this legislation as well. But I would also like to let you know that the Labor Committee, and I say this with some trepidation, but also has the expertise and time to consider this legislation if you would choose to re-refer it. And I thank you for your consideration, and I'm happy to answer any questions.
Thank you, Senator. Questions? Senator Bailey?
Thank you, Madam Chair. So Senator Tipping, I'm looking at the recommendation in the report, and the recommendation, which was a majority of the commission, was to prohibit non-compete clauses and non-disparagement clauses. But the bill just seems to be addressing non-compete clauses. Can you help me understand that?
Yeah, I think with all of the legislation that we ended up recommending and that the committee reported out, I think the intent was to find the simplest pathway here. And this is simply adding one definition and one line to the current non-compete prohibition that actually is where the veterinarian piece is included. So I think the idea there is to just modify that law a little bit rather than add too much to it. But if you would like to consider broadening it, including anti-disparagement, I think that would be appropriate. I think some of those would be covered under the definition here of non-compete as well.
So it was really because we already have a section of statute that deals with non-compete, as you mentioned, with veterinarians, that this would just be, if you will, fairly straightforward to just add this there. And we don't have a similar statutory provision in regards to non-disparagement clauses.
That is my recollection. It's been a little bit since we dealt with this area of law. I would say that very statute not only covers veterinarians, but also employees earning wages at or below 400% of the federal poverty level.
Thank you.
Representative Mastracchio.
No, this never.
I'll turn mine off for a sec.
Mine.
That's it. You reached your limit.
There we go. Can you hear me, Senator Tipping? So my question is about the non-competes, because it seems to me we've been dealing with those for a long time. So really the only progress we've made, at least in my time in the legislature, since the 126th is non-competes for veterinarians.
That's right. We have it now for healthcare providers for animals. This is an opportunity to have it for healthcare providers for humans. I would say there was obviously the federal regulation that was passed outlining these as a non-competitive trade practice, but that was repealed after the Biden administration there.
And so you're saying that you don't have any bills around non-compete clauses in your committee right now, then?
Not that I'm aware of.
Okay, I just wondered, you don't have a problem with us. I mean, obviously you're here testifying for it. I assume you would rather it was broader.
Yes, I'm happy with any movement
any
in the right
inroads?
direction here.
Okay.
And in terms of jurisdiction, I was surprised to see it referred to HCIFS, but I have no problem with that.
Representative Olson.
Thank you, Madam Chair. Do we have any data on non-competes that have been litigated and were they sustained or upheld?
I don't have good data on that. I'd be happy to come back. I do know that they have been successfully challenged in some cases.
Additional questions from committee members? Seeing none, thank you for your time, Senator. Is there everybody in the room that would like to testify in favor of this bill? Nope. We have someone online, James. Oh, we do. Oh, sorry, Trev. I didn't see you walking up. Thank you.
Good afternoon, Senator Bailey, Representative Matheson, members of the committee. Once again, I'm Trevor Putnaki from the Healthcare Purchaser Alliance. This is another topic that came up in the commission work that I participated in. And I think, frankly, it really comes down to just the issue of access within the state of Maine. We all know that it's hard to find providers. It's hard to attract providers in the state of Maine. And so when providers are put under these non-compete agreements, ostensibly, if they want to leave their place of employment, they may have to go then leave the state entirely, and we lose access to that. There are other states that have been pursuing non-competes for providers. Today, 10 states ban non-compete clauses for healthcare practitioners, and among the 38 states that either ban or limit non-compete clauses, generally, 22 include enhanced protections for healthcare workers, underscoring the singular risk that non-compete clauses can pose to patient health by disrupting continuity of care and limiting physician choice and access to care. And we've all heard stories of folks who have to go to Boston to get an appointment or can't get in to see a specialist for 6 months or a year. I mean, to me, this is just about making sure that we're not losing providers to another state when we have such a provider shortage as it is already. And as Senator Tipping noted, the legislature has already banned non-competes for veterinarians. So I think it makes sense perhaps to consider it for human doctors as well. Yeah, I think that's pretty much the only point I want to make here, right? We don't want to exacerbate the access problems and continuity of care problems. I get the argument that provider groups invest a lot into their workforce and helping them build panels and help them, establish these relationships. And I'm sympathetic to that. I don't want to see providers leaving and taking every patient with them. But at the same time, I think the bigger problem is just access to providers at all. And, if veterinarians can't hold employees captive, then I think providers shouldn't be allowed to hold their employees captive either.
Thank you. Questions? Representative Mastrocchio.
Thank you, Madam Chair. I'm trying to find out if, how many, so now we have a lot of, I'm just going to use an example as a hospitalist, and maybe those people, there will be people coming up that will answer it, but it just seems to me, are they making them sign a non-compete agreement now? I mean, are there a lot of them out there in Maine?
I don't know the answer to that.
That would be.
I
mean,
tried to
we're
figure
trying to
out
ban
like how
something that
common are
doesn't
these
exist.
things? Yeah, how often are they going to court and looking? I looked into that question as well. It's really hard to find any data to answer
Right.
those questions. I mean, it's possible that they're not very common at all, and in that case, then I would think the the impact on provider organizations who would oppose this would be relatively
Right,
minimal.
and because I'm just trying to figure out, I remember years ago, it was fairly common if somebody brought you to an area and hired you to do it, like work in a practice, they made you sign a non-compete. And nobody really questioned it, and it meant that if you left them, you really couldn't compete in the area there. You had to go to another part of the state or leave the state.
Yeah.
So I am really, if we can find out how many of these healthcare entities are actually making people sign non-competes, I would really like to know if it's a problem.
I would love to know that too. And one other point on that I would note is that, when we have these really large consolidated health systems, it's not like you can go in a different catchment area if you have a non-compete that you can't be in 60 miles of their one of their organizations. I don't know how they're structured. Not an expert on this. And again, I wish we had more information. The only point I'm really trying to make is if we're trying to keep providers in the state of Maine, non-competes potentially would lead to more providers leaving the state.
Additional questions? Representative Hartford?
Yeah. Yes, hello.
I'm sorry, I thought Representative Olson was going to ask a question.
So I'm not sure if you are the correct person, but if you are, I'm going to ask this because it is something I just realized I would like to understand. I'm not seeing a complete definition of what non-complete clause would include. Have you, whether or not you know what the legal definition is your understanding that a non-complete clause would also include the healthcare practitioners? Let's say they were excused from their place of employment and they had one of these non-compete clauses and they were engaged in very extensive, because of the nature of their, say they were like, for instance, a doctor, especially doctor that had long-term, long-standing relationships with their patient. Would this prevent someone from having any contact whatsoever with their patients after their date of employ, after they were dismissed?
I think, non-compete agreements can exist in a sort of a spectrum of how strict they are about what you can do. I mean, you could have different non-compete clauses saying you can't practice within 20 miles or 50 miles or 100 miles. So it's hard to sort of paint them with a broad brush. I think it's probably a common practice to say you're not allowed to go and solicit patients from the practice that you just left. And I think that makes sense. But I don't know whether they would stop a provider from accepting a patient who leaves their practice of their own volition and wants to go see the specialist at a different location. I would think that that would not be prohibited, but I don't know. I think it would probably be dependent on the specific non-compete that they signed.
Oh, thank you.
Additional questions? Representative Olson? Representative Hartford?
Thank you, Madam Chair. If this would prohibit non-competes altogether, correctly? Is there a time, in your opinion, where a non-compete would be desirable? So, for example, if someone were to bring in someone and say, we'll bring you in, we're going to pay you, we're going to move you, we're going to pay all your medical debt. But as a quid pro quo, you're going to sign this non-compete. Would this, if it went through like that, prohibit that? And then does that limit the ability for recruitment?
I think in that case, yeah, you may be enticed to sign some level of non-compete. I think what would be ideal is just not forcing people to sign non-compete sort of on a blanket basis as a condition of employment there. I mean, I could see a situation where an employer says, we're going to, pay off your student loan debt and we're going to give you this salary, but we don't want you to, we're going to require that you're going to sign an agreement in exchange for these things. So maybe there is some nuance that you could put into this bill to allow folks with the to sort of negotiate that. But I think requiring them as a condition of employment is probably a bridge too far and should not be allowed.
Additional questions? Seeing none, thank you for your testimony.
Thank you.
Is there anybody else in the room who would like to testify in favor of this bill?
Good afternoon, Senator Bailey, Representative Matheson, and members of the committee. My name is Kate Endy, and I'm the Policy Director of Consumers for Affordable Healthcare. Apologize, I do not have any written testimony, but I'll be very brief. I would say we agree with the information you've already heard around non-competes potentially having negative impact on access in certain communities. We think it's important that providers are able to practice in the communities where they live if they so choose to and aren't limited by these contract provisions that could potentially lead to somebody leaving the state or leaving the community where they live. So for those reasons, we're supportive of the bill.
Thank you. Questions from committee members? Seeing
Thank
none,
you.
thank you for your testimony. Are there additional people who would like to testify in favor of this bill? Seeing none, I think we have one online. James? Welcome, James.
Everyone, can you hear me?
Yes, we can. Thank you.
Okay, great. Good afternoon, Senator Bailey, Representative Matheson, members of the Joint Standing Committee. My name is James Mile. I'm a policy analyst at the Maine Center for Economic Policy, and I'm testifying today in support of LD 2200. MECED supports LD 2200 because non-compete agreements distort the labor market, reduce worker power, and harm patients. In general, non-compete agreements benefit employers at the detriment of workers. They are sometimes portrayed as a negotiation between each party, but one large national survey found that only 10% of employees with a non-compete agreement actually negotiated them, and a third of the folks who had them received a non-compete agreement after they'd already accepted a job offer. In a labor market like healthcare in Maine, which is dominated by a handful of large healthcare systems, the power imbalance is tilted even further in favor of the employer. Non-compete agreements allow employers to reduce labor market mobility and to stifle employee bargaining power. In that way, they hurt both individual workers and the economy as a whole. When workers are prevented from changing jobs by a non-compete agreement, it means they can't move to a new job with better working conditions or higher wages. It also means their current employer doesn't have to offer them better terms to stop them moving. The overall effect of that is to hold down wages and benefits, and that effect is particularly large for women and people of color. At the same time, restricting worker mobility is harmful for the economy more broadly. When a non-compete agreement prevents a nurse or a doctor from switching jobs, it also means a hospital with a greater need for providers can't always find them. Non-compete agreements stop the labor market functioning the way it should do and matching the supply of labor to the demand of services. And as I'm sure you know, this ultimately impacts patients. When a hospital can't find employees because they're tied up in non-compete agreements, it means patients can face longer waiting times, have less choice about what doctor ultimately sees them, or worse care from the overworked staff who are available. One study found that states that restricted non-agreements have more physicians and more practices. Thank you for your time. I would urge you to vote all to pass in LD 2200, and I'm happy to answer any questions.
Thank you for your testimony. Questions from committee members? Seeing none, thank you for your time today. Is there anybody in the room like to testify in opposition to this bill? Is there anybody in the room like to testify neither for nor against this bill?
Good afternoon again, Senator Bailey, Representative Matheson, members of the committee, Andy McLean again, speaking on behalf of the Maine Medical Association and the Maine Osteopathic Association. I don't have written testimony. I wasn't sure whether I would speak to this, but I do think that I can provide some information. You do have a letter in support of the bill, in support of prohibiting these, from the American Osteopathic Association and the Maine Osteopathic Association. We are speaking neither for nor against the bill because we truly have heard a variety of views on this topic, not surprisingly, depending on where the physician sits. If the physician is looking at it from an employee perspective, they don't like these things. If you're a physician in leadership or owner of an organization, you may feel that it's important to have this tool to protect your business. Now, to some of the questions that have come up, we review physician employment agreements on behalf of physicians as a service. So I've read these for 25 years or more. So a couple of observations. They are far less common today than they were 25 years ago. They are more common in private practices than in hospitals or health systems. I think that is because, think about it, you've got private physician capital on the line, investment in these organizations. They're quite concerned about protecting the investment. To the law, you've obviously seen Section 599A from the labor laws this bill seeks to amend. The leading law court case, at least in the healthcare sector, is a case from 1995 called Brignall. That's Brignull v. Albert. This dealt with an optometry practice in Ellsworth, and it basically stands for the proposition that these are enforceable in Maine with limits. There are 3 limits. They have to be reasonable in their geographic reach, their duration, and the business interest to be protected. Now, there might be various views on what the business interest is, but it's been, I think Trevor mentioned it, that basically it's that the practice invests in the training of a young physician and shouldn't be able to run off and use it in competition. The other 2, I have generally seen in terms of geographic reach, somewhere between 15 and 35 miles from the principal place of practice typically. And duration, I've seen typically 12, 18, or 24 months. The final thing I'll say is that there also is an AMA Code of Ethics provision that it's negative in that these limit patient choice is the primary focus of the ethics opinion. That is opinion 11.2.3.1 entitled Restrictive Covenants. Now, one last thing, these restrictive covenants typically come in 3s. And when you're talking about non-competes, you're really talking about that geographic restriction on the right to practice for a certain period of time within a geographic region after termination of the employment agreement. The other 2, frankly, I don't think most people would argue about. Those are, you can't solicit employees or agents of the organization. So for the physician, you can't leave and take your MA and your nurse with you. And you can't solicit directly patients. Now, that does not mean that a physician who leaves is perfectly able to set up a website or put an ad in a publication and say, I'm open for business, but you can't directly solicit patients. With that, I'd be happy to answer any questions.
Representative Mastracchio.
Thank you, Madam Chair. So I'm just thinking about how you enforce these. And basically, you have to take somebody to court. And it kind of leaves the person who's being taken to court, the person who may be, you know, at the beginning of their career maybe and doesn't have as much money, kind of leaves them, you know, they don't really have a lot of choice, so they might just give into it and not want to fight it. Do you know of organizations that have, I mean, other than that court case, and I would really like to see that, if you can get us any of that kind of information. I'm just wondering, I think I was reading something that some states just make them unenforceable.
Well, I think that's essentially what you're talking about doing.
Well, we are,
Yeah.
but I mean, I think we should do them for, I'm sorry, I think generally, I don't think that we should be picking and choosing because I think where the labor market is the way it is, that's why we're talking about it.
I didn't research that, the litigation. I don't believe that we would find there's a lot of litigation on this. And I think the way organizations react to these, again, is varied. I have seen it not infrequently that the practice will waive the provision. The physician is spent, 5-10 years has really helped the practice. They want to go do something else. The practice says, fine, go do it. And they release them from it. The other thing that you will see that hasn't been mentioned yet, I don't think, is that these provisions in employment agreements typically have a liquidated damages provision, which is substantial oftentimes. This is basically just by contract, the person is agreeing to the employer's damages. It is often couched in a percentage of annual salary. Could be a year's salary. Sometimes those are referred to as buyout provisions. So the physician is fine to leave if they're willing to pay the liquidated damages provision.
Representative Barford.
Yeah, thank you, Madam Chair, and thank you for being here. I'm glad you decided to testify. I have 3 quick questions. Non-compete, when a provider is let go, fired, however you want to, that would trigger a non-compete as well as someone willingly leaving a practice. Is that correct? I mean, from your
No, I mean, that's a great question. And I don't know that has ever been litigated, but let me my opinion would be that it'd be very difficult for an employer to fire a physician and then try to enforce the non-compete. I think, you can't absolutely, I mean, it's in the limits, that Brignall puts on these. You can't, prohibit someone from earning a living in the entire state of Maine. So,
well, I have 2 other, I just will say that in 2008, our family was the recipient of a beloved provider being terminated at a practice and us not being able to have any contact with them because of the agreement. But anyhow, moving on, when you say, when you're talking about how the agreement would impact a person's ability to solicit patients, you're saying it does not include simply putting an ad in the local paper and saying, I'm now setting, I'm so-and-so and I'm setting up my own practice and I'm welcoming patients. That would not be considered solicitation.
I do not think that would be in violation of a non-solicitation.
Right. And
provision.
like that, if you simply somehow notified the staff that you'd worked with that you were looking for staff, that would not, it wasn't a direct ask of them, just again.
I think that's probably fair too. Obviously, what you clearly would not do is use the practice's equipment or, patient list, employee list to, that would be a direct solicitation.
Yeah. And my last question is, how does this agreement can you imagine any way or share any way that you believe this agreement would serve the patient's interest? You said it might serve the owner of the practice's interest to have these in place.
Sure.
But how would it serve the patient's
Yeah, I mean,
interest?
I think, given other factors and forces in the market, a situation where this might benefit a patient is where you have a highly specialized clinician in a practice where there may be one or two practices of this type in the state. Certainly if the physician has an incentive, this sort of incentive to stay in the practice, that's going to benefit the patients of that highly specialized practice.
Thank you so much.
Thanks.
I had just one clarifying question. Thank you so much. So as an owner of a private practice who no longer does non-competes, but understands the business interest of non-competes with bringing in new doctors and setting them up and getting them to be seeing a lot of patients. I understand that type. I'm curious, when you say these non-competes can have restrictive covenants, for instance, soliciting directly patients and soliciting employers. If we ban non-competes in the state, does an employer still have the right to be able to identify that a doctor can't solicit patients?
Yeah, no, I didn't read this bill to be intending to deal with those other two restrictive covenants. I think you're only talking about the geographic restriction.
That was my understanding as well, but I appreciate that clarification. Thank you. Sure. Additional questions? Seeing none, thank you very much for your testimony.
Senator Bailey, Representative Matheson, members of the committee, Ann Robinson, Pierce Atwood, and again, on behalf of Spectrum Healthcare Partners, if you'll indulge me, I'm sorry, I was checking my notes and didn't hear you say opponents. And so I had intended to testify as an opponent. And so just to be intellectually honest about my position, we are not neither for nor against. So if you allow me to testify in this category,
absolutely,
I'd appreciate it. But
thank you.
So again, Spectrum is a multi-specialty physician practice group, a large practice group here in Maine. And so some of the specialties that are provided are anesthesiology, radiology, pathology. And there are two reasons really why Spectrum uses a type of non-compete agreement. And it's one that was discussed in previous testimony, which is, the buyout version, in which there's a geographic restriction, but if the departing physician wants to leave and practice within that area, they can do so. But there's an expectation through this agreement that there'd be some compensation to the practice that's reflective of the costs that the practice has incurred in recruiting and training that physician. Also, part of that recruitment process is the added, oftentimes, not always, but costs of the immigration process, helping them get appropriate visas and the like. And so there's a lot of investment on the part of the practice in recruiting them. Not to mention the reputational value and goodwill benefit that the physician enjoys and benefits from that relationship. But the other aspect is the importance of the practice being able to have stability and predictability with its workforce and being able to staff or to meet the staffing obligations that it has contractually with the healthcare facilities that it services. So, for example, if in this case, say Spectrum makes a commitment that they're going to provide anesthesiology services or radio, whatever it might be, to a hospital, say in a rural area, and they're going to incur that cost and make that commitment to provide those services in a low density area, they need to know that they're going to have the people to fulfill those obligations, at least for, a period of time. So to, I guess, Representative Arford's question about, are there patient benefits? I would suggest to you that that is a patient benefit, is having that kind of commitment and stability at large, but, in particularly in areas where there's, perhaps otherwise more likely that the person might want to leave that rural area and move to, Portland or someplace further south. So I also wanted to say that regarding the, the legislation that's been spoken of from the last biennium, the governor did veto that the Department of Labor had testified in opposition to that bill and had noted that they had had very few inquiries at all regarding non-compete agreements and no complaints, and thought that non-compete agreements did serve a useful purpose for all employers. And it was certainly well known, we testified at the time, that these were of importance and value in the healthcare sector. And so I think the policy decision that was made and the department's position, was with the knowledge and reflective of that. So with that, I'll close. I'm happy to answer any questions. Thank you.
Questions from committee members? I don't know if you can divulge this, but I was just curious whether or not you had a set duration or a geographic span that you typically use with these non-disclosure, or is that just proprietary information?
No, I need to get back to you on the specifics of it. I need to do that between now and the work session.
Thank you very much.
Thank you.
Are there additional people who would like to testify neither for nor against this bill?
Representative Matheson, Senator Bailey, members of the committee. My name is Jeff Austin here on behalf of the Maine Hospital Association. Testifying neither for nor against. I just really wanted to answer two questions. Representative Mastraccio sort of asked if we use them today. We asked our members. Largely no is what I heard. I don't have an inventory. I can't say there aren't some lingering out there, but I did want to answer the question we asked. My guess is it's a leverage issue. We are buyers of talent, and it is not a buyer's market. It's a seller's market. In most of the state, if you slide a non-compete in front of a clinician, they're going to laugh at you. So I don't think we're really using them mostly because the market. But I also wanted to answer Representative Arford's question. Why would a patient like it? I stand up here a lot and talk about how our finances are kind of a house of cards. And so if you have a hospital practice, if someone wants to come into town and compete, have at it. They got to get space. They got to equip it. They got to hire people. They got to do insurances and billing and advertising it. It's expensive. So they come in and they work for us first, where they don't have to bear any of those upfront costs. And our practices, let's say it's a primary care practice, has a mix of patients, Medicare, Medicaid, commercially insured. Our concern is always they get there, they have no connection to community. She's a great doctor. Everybody loves her. Moves across the street, opens a practice that caters only to the commercial. That remaining hospital practice, the financial viability of that practice is now in doubt. We needed a mix. We need 40% commercial and 40% Medicare and 15% Medicaid. If that gets out of whack, the financial underpinnings of that practice can come in doubt. So everyone talks about this as about saving access. When you're the one left behind, it depends on what leaves. If it's a full patient mix, including the uninsured and Medicaid, then probably we're okay. But if it's a direct primary care practice that caters to a certain population and doesn't include Medicaid, the remaining practice, that viability might be in doubt. That's how a Medicaid patient might care. But again, we ain't using them. I mean, you just don't have the leverage to do them these days. So we don't, we have no real position on the bill.
Thank you. Questions from committee members? Thank you for your testimony. Are there additional people that would like to testify neither for nor against? Time is my bills.
It's got to be a joke here about a buyer of talent and Jeff and Dan, but I just can't come up with it. So maybe I'm not the talented I think I am.
Maybe not.
Maybe not. Senator Bailey, Representative Matheson, members of the committee, and Dan Demerit with the Maine Association of Health Plans. We don't take a position on the underlying intent of LD 2200. and its attempt to reduce restrictions on the employment of physicians and other licensed healthcare professionals as it relates to their areas of clinical practice. There are some definitional and structural elements of the bill that warrant refinement, and we wanted to bring those to your attention in terms of employment by health insurance carriers or other entities. We think the definition of healthcare practitioner could be overly broad in that, as proposed in Section 1 of the bill, it would apply to many health plan employees who maintain their professional licenses but serve in administrative, pharmacy, clinical review, and utilization review roles for health plans. They're not working in direct patient care, but they are using their expertise and are maintaining their professional licenses. The definition could also apply for professionals working in sales or other corporate functions within a carrier that still retain their credentials but are not engaged in clinical practice. In both examples, a health insurance carrier may appropriately request, I don't know if we're buyers or sellers of talent, but may appropriately request a non-compete clause as a condition of employment to protect their trade secrets and proprietary information from being shared with a competing carrier without restricting a person's ability to accept employment as a healthcare provider. So for us, it's about preserving business value and not limiting the practice of medicine. We did like the veterinary pieces come up a couple different times, and we align with that. And we think it makes some sense too on the ownership interest exemption for healthcare practitioners. We think it makes sense to carry that piece forward if the committee does decide to move this bill forward. And it makes sense to protect the ownership value without limiting a clinician's ability to practice medicine if they happen to have an ownership interest, as is the case in existing law. And we'd ask for those two items if the committee is advancing this bill. Happy to try and answer any questions.
Thank you, Mr. Demerit. Representative Boyer.
Thank you, Madam Chair. Thank you, Dan. Dan, I had actually heard this from a practice owner. Is this sort of where practices are moving, is sort of to give an ownership interest?
To attract people, like in
to
little
attract people
equity.
and
Yeah.
maybe to get ahead of like if we were to prohibit non-competes. Like,
Yeah. I'm not familiar with that in terms of trying to attract, it's outside my space that I work with the health plans in terms of trying to set up healthcare practices and the enticements they may use to do that. So I'd have a hard time answering that question for you.
Okay. Thanks.
Right? I don't, yeah. Yep. Okay. Yep.
Additional questions from committee members? Representative Arford?
If you know this, I'd love you to respond, but I
Sure.
know you may not. Because you bring it up about your idea about narrowing the healthcare practitioner term to apply just to those who are licensed in a clinical role versus an administrative role. Do you know, I know you travel around a little bit in your work as an insurance representing insurers, and have you spoken with people in other states? Do you know anything about what's happening in other parts of the country specifically around that
In terms of narrowing the scope of the
Yeah.
healthcare practitioner,
when it comes to non-competes?
I don't know how they would limit it in other states. We raised the question about potentially limiting it to, impacting clinical practice as opposed to other areas of employment where it may be more I don't know if more appropriate is the right term, but it may apply from a business perspective. It's different.
Okay, thank you.
Additional questions from committee members?
Thank you.
None. Thank you for your testimony. Is there anybody else in the room that'd like to testify neither for nor against this bill? We don't have anybody online. Are there any requests for calling for the work session? Senator Bailey.
So Mr. Pranutti's testimony indicated that there were other states and then some states that kind of have a variation. I'd just like to kind of get an overview if you could do that. Holly, thank you.
Thank you. We'll close the public hearing for LD 2200. I'll hand it over to my colleague.
We will open the public hearing on LD 2201.
Right. Good afternoon. It's me again. Senator Bailey, Representative Matheson, members of the Health Coverage, Insurance and Financial Services Committee. My name is still Michelle Boyer, and I still represent House District 123, which is part of Cape Elizabeth. It's an honor to come before you today to introduce LD 2201, an act to implement certain recommendations related to the regulatory review and approval of certain healthcare transactions involving private equity companies, hedge funds, or management services organizations from the Commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. LD 2201 develops a regulatory process for review and approval of transactions when a private equity company, hedge fund, or management services organization acquires a majority ownership interest in a healthcare entity, or when a private equity company, hedge fund, or management services organization takes operational control over a healthcare entity. The negative impact of private equity financing on healthcare has been well documented. Increased mortality for patients, rise in adverse events, price inflation, and excessive charges are just a few of those impacts. Many states are moving to a market transaction overview process to better understand and protect their healthcare entities. States such as Oregon, New Mexico, Minnesota, and Massachusetts, to name a few. Our current certificate of need process focuses on the cost of project reviewed to the state's Medicaid system. LD 2201 requires a more comprehensive review, including how the transaction may affect cost, quality, or equity of access to healthcare in the state. As well, LD 2201 allows a review of the effects of vertical or cross-market transactions and how that may impact costs and quality of care in the state. And I'll just add, because I think it was brought up before when we were looking at the bill that looked at making some changes to certificate of need, that there is a bit of overlap here. So the committee could probably decide which bill they liked more, if either, to move forward. But happy to answer any questions.
All right, questions from committee members? Not seeing any. Thank you very
Wow,
much.
those were easy on me. Thanks.
Anyone in the room wishing to testify in favor of this bill?
Good afternoon, Senator Bailey and members of the committee. I am Meg Garrett-Reed, Executive Director of the Office of Affordable Healthcare, here to testify in support of LD 2201. I'm not going to read my testimony. I think it touches on a lot of issues that have been discussed in great depth today. I would just say I think this bill is based on a structure that was outlined in legislation that we brought to the committee and discussed during the last session. I believe it's a well thought out structure that takes lessons from other states for how to review transactions. And in this case, I think responds to some stakeholder concerns about breadth by narrowing the focus to focus in on transactions involving entities that may present a higher risk of adverse outcomes for consumers. And lastly, I know while I was out of the room, there was some discussion about terminology and defining terms. So would just reiterate, we're happy to take a look back at those states that do have similar programs and take a look at both their statute and regulation and bring back some information to the committee about how they've approached those issues.
Thank you. Questions from committee members? Seeing none, thank you very much.
Thank you.
Anyone else in the room wishing to testify in favor of this bill?
Good afternoon, Senator Bailey and members of the committee. Thank you again for the opportunity to testify in support of LD 2201. My name is Kate Endy, and I'm the Policy Director at Consumers for Affordable Healthcare. I think during the previous hearings today, I've outlined my concerns around private equity and the role private equity can play in healthcare and the impacts that that can have on availability of services, quality of services, and cost. So I won't read my entire testimony, but I would just say that as we are seeing an increasing financialization of healthcare throughout the country, and I think as our health system changes, oversight also needs to evolve. And I think that this bill aims to do just that, to adapt it to our to current challenges in healthcare system and to ensure that mergers and acquisitions are going to meet the best needs of Maine communities and people, and not just a firm's stockholders. Happy to answer any questions.
Okay, thank you. Any questions from committee members? Not seeing any. Thank you. Anyone else wishing to testify in favor of this bill?
Senator Bailey, Representative Matheson, members of the committee. My name is Bill Monteo. I'm the Director of the Division of Licensing within the Department of Health and Human Services, and we're providing testimony in support of this bill. And I will follow Director Garrett Reed's lead and say I will not read my testimony verbatim to you, but would encourage you to pass this bill. We view this as a really more comprehensive bill to address many of the issues that have come up before. As Mr. Lawrence testified earlier in relation to LD 1890, excuse me, or 2190. Thank you. Not enough coffee. I swore I'd be well caffeinated before I got here. And also, as Representative Boyer, when she presented this bill, testified that there are many areas of overlap. We view this bill as really the most comprehensive bill to address issues with private equity concerns and also issues that came up earlier about looking at access and affordability statewide by really partnering two offices, the Office of Affordable Healthcare and the Division of Licensing Certificate of Need program, to look at the respective areas that we have expertise and work collaboratively to accomplish these goals. And we think this bill affords that opportunity to do that and to move things forward.
Great, thank you. Questions from committee members? Seeing none, thank you very much. Anyone else wishing to testify in favor of this bill? Anyone wishing to testify in opposition to this bill?
Good afternoon once again, Senator Bailey, members of the committee. Thank you for your patience with me today. Andy McLean again with the Maine Medical Association and the Maine Osteopathic Association, speaking in opposition to LD 2201. As a reminder, we combined our written testimony on both 2190 and 2201. I want to add to, remember in my testimony on 2190, I asked you to consider preserving an environment in which independent private physician practices in Maine can thrive. I didn't really tell you why anyone should care. I think that's about choice. It's important as part of our physician recruitment efforts, our physician workforce issues that we have in Maine, that we can offer a private practice environment in which to work. And I think it's also important from a patient standpoint that there is choice in practitioner setting. Now, on the private equity issue, I've got to begin by saying that I think the Stewart experience in Massachusetts has had an outsized impact on the policy debate here in Maine. You heard Mr. Austin say earlier that this bill really doesn't affect hospitals. All Maine hospitals are currently nonprofit. We don't have a history of for-profit healthcare in this state. We don't have a strong culture of that would promote for-profit hospitals. So this bill very quickly gets narrowed to focus on independent private physician practices, private physician investment, and I fear that adding this bill with the review of material change transactions adds an entirely new layer of regulation adjacent to or grafted onto our CON framework. And I worry that the costs involved in this review could render this type of financing to be, essentially unavailable to practices. I have spoken with, I don't know if this is the case, but there are other financing mechanisms that physician practices are using to try to deal with the changing environment that we're in. ESOP form, for example. I've chatted with practices that have considered employee ownership. Wouldn't want those, prohibited either. So that's my concern, or our concern about this. To the market, as I've observed it, we have very little private equity financing, even in the physician practice part of the sector in Maine. I can think of, I could certainly count them on one hand. And to the questions that have been raised about, are there positive examples of private equity financing in physician practices? Yes. I'm reluctant, because of the conversation, I'm reluctant to name the practice on mic, but I'm happy to connect any one of you individually with a representative of a practice that has recently used private equity financing. And because they have been very careful about the governance structure and the governance model to retain physician control over operations and clinical decisions, they're quite happy. They feel that this is the route to being able to recruit new physicians to Maine and to serve Maine patients in the way they'd like to. So,
Okay.
Thanks.
Thank you. Questions from committee members? Seeing none? Thank
Okay,
you very much.
thanks.
Oh, Representative Arford.
Yeah, I did have a quick question. By the way, thank you again for choosing to be here today and testify. It's excellent information. Am I correct in thinking that any sort of long-term care nursing facility would be covered under this bill or not?
I believe not.
Not? So no residential care facilities that are are seen as, it would not be covered. Okay, so we're just talking about direct care delivery entities.
I think you need to look at the definitions. in the
Okay,
bill.
okay, but anyhow, no, regardless, I would be interested in, not in this moment, but for the work session, any factual and data information you have on where the presence of a private equity entity has been of value within the state of Maine. I mean, positive value, has worked well for both the providers, the owners, and the patients.
Sure.
Thank you.
Okay, any other questions?
Thanks.
Seeing none, thank you. Anyone else wishing to testify in opposition to this bill?
There, good afternoon, Senator Bailey, Commission members. My name is Lisa Harvey McPherson, and I'm here today to speak in opposition to this bill on behalf of Northern Light Health. During the Commission deliberations, members discussed private equity and hedge funding practices in other states that include private equity purchases resulting in mandated management service organization services for the healthcare entity at payment rates that drain cash and direct profit-oriented business practices. We do believe this was the intent of including management service organizations in this bill. Unfortunately, because of the definition of MSOs, this bill goes far beyond the MSO arrangement discussed by the Commission, and we believe negatively will impact health systems like Northern Light. We are a statewide healthcare system with a parent organization structure, and we provide a variety of management services to our organization members. Centralized human resources, legal, finance, risk management, and contracted services that benefit all of our member organizations. And we are facing financially challenging, high risk, and an uncertain healthcare environment, and our ability to consolidate costs and achieve efficiencies is an essential business practice. So we contract with business partners that bring value to our health system and the communities we serve. We contract for clinical lab services, nutrition and environmental services, and these have resulted in significant savings while providing our patients and member organizations with high-quality services. We also contract with a national business partner, bringing national-level expertise and resources to our health system for revenue cycle, care management, clinical and business information systems, and data analytics. The savings are achieved when healthcare infrastructure costs are eliminated in a contracted services model. So the bill before you today would subject health systems like our not-for-profit health system to a burdensome regulatory review process that we believe the Commission intended to align with private equity hedge fund transactions and not be so broad to impact not-for-profit healthcare in the state of Maine. And as Mr. Austin mentioned this morning, throughout the Commission discussion, hospital members did emphasize support for the existing CON regulatory structure and recommendations to strengthen the CON division with financial resources provided by the private equity entity to effectively regulate private equity and hedge fund transactions for Maine. And we do think that this is the right government structure for oversight. And I welcome any questions that you have.
Thank you. Questions from committee members? Not seeing any. Thank you.
Thank you.
Anyone else wishing to testify in opposition to this bill?
Back again. Senator Bailey, members of the committee, my name is Dan Demerit. I am the Executive Director of the Maine Association of Health Plans. MEAP is opposed to LD 2201 because it would increase costs for members and employers by establishing healthcare members and employers by establishing a precedent-setting assessment on carriers despite not intending to regulate their activities. We had the same concern with this assessment when it was proposed last year as part of LD 1972, a healthcare transaction and transparency bill that was reported out not to pass by the committee in May of 2025. We're also concerned that the new oversight structure created by the bill could extend to ownership and operational models that deliver healthcare innovations that are distinct from the Commission's focus on private equity firms and hedge fund investors. For the precedent-setting assessment, the proposed assessment in Section 372, Item 6, on page 8, line 30, sets the precedent that health insurance carriers should be responsible for paying for the cost of regulating, providing oversight for healthcare providers. Starts out seemingly small, but has the potential to become yet another and easy to grow funding source for state operations that applies to the approximately 220,000 Maine consumers with employers with fully insured health plans in our state. We would also share a concern raised by subject matter experts that work for our plans with the committee that the notice of the proposed material change transactions in section 372, page 2, line 28 of the bill is inconsistent with the timelines established in U.S. antitrust statute. Now, I'm no antitrust lawyer, and a couple bills ago, I was not an employment lawyer, but I'm good at synthesizing information from subject matter experts and providing links to more information. So we wanted to point you to HSR Hart-Scott-Rodino and how it provides for a 30-day notice and waiting period for initial review by the Federal Trade Commission and the Antitrust Division of the Department of Justice. There's also a potential to extend that review under the federal law if agencies request additional information. Finally, we would speak to urging narrowing the scope to private equity and hedge fund ownership. As others have said before me, in regard to this bill, it was our expectation from the work of the commission that the focus would be on the practices of these types of firms. And we would point out that health plans and PBMs are offering coverage innovations that include access to virtual and telehealth care to provide members with immediate access to healthcare experts and resources. We're concerned that the broad definition of management service organizations and the burdens that we put in place by this bill could limit ability for innovative service models to be developed through, with different ownership arrangements and operational control agreements that have the potential to deliver value for healthcare providers and facilities. So with that, we'd ask if the committee advances the bill that you consider stripping the health insurance assessment and narrowing the focus of the bill to transactions involving direct private equity and hedge fund ownership. And with that, I'd be happy to answer any questions.
Okay, thank you. Questions from committee members? So are you suggesting that we just take MSOs out, or do you have suggestions on how we can tweak that definition so that it doesn't scoop up these?
Yeah, I'd like to.
We heard that from Northern Light as well, that, and I don't think that was the intent of the bill.
Yeah. Yeah, no, I read Lisa's testimony while she was giving it, and I don't want to go back to my members and talk about a specific response to your question, but I liked her focus on the face. I like to focus on the concern about pulling profits or costs out of these MSO, forcing entities to use these MSOs at certain prices and things like that. That does seem kind of predatory is probably not the right word, but it seems potentially excessive. So I go back to, if you'd indulge, go back to our plans, talk about your question, and see if we can't come back with a language suggestion before the work session. Appreciate the opportunity.
Yeah, thank you.
Which is probably what I should have just said in the first place.
Thank you. Any other questions?
Okay.
Seeing none.
Thank you.
Thank you. Anyone else wishing to testify in opposition?
Senator Bailey, members of the committee, my name is Jeff Austin. I'm here to speak in opposition to the bill. I'm really not all that in opposition to the bill, and you can skip the first page of my testimony and just go to the second page. Our issue is the MSO definition. That's really it. The first page just says, I don't think we really need it. This is really kind of based on the Oregon law. Oregon has CON, but I think only for new construction. I'm not an expert in Oregon. I don't think they have it for transfers. So they needed something if they wanted to review transfers. We have a CON that includes transfers, but that's not my point. The point is the MSO. It's at the top of page 2 of the bill. And yes, the commission heard testimony that MSOs can be misused. They are used regularly. Our systems are MSOs. There's plenty of MSOs, and MSOs, as Chris Ossenfort said, are not inherently wrong, but they can be misused. And that's what they heard. That's what the commission heard in testimony was, it can be, if you're going to break into the bank, are you going to break in through the front door or the ceiling or the basement? And this is one of the ways you can break into the bank, is if you misuse an MSO to extract value out of the entity. So I'm not wedded to this language. I think this is what the commission heard. It's that when the MSO owns the facility, let's say a hospital. So, excuse me, when the private equity owns the hospital and they own the MSO and they use the MSO as a way to pull all the equity and all the value out of the facility. So that was what they heard about. As I read, I mean, Director Garrett speaks for herself. That's what I read in her testimony is it's focused on private equity. I see that term a lot, half dozen times. So I think that's what it was about, but as long as that's taken care of, we're neither for nor against on the bill. I'm happy to take any questions.
Oh, thank you. Any questions from committee members? Thank you for providing at least a draft. And I like that it does say own or control because I think that's the issue.
It's complicated.
Thank you. Anyone else wishing to testify in opposition to this bill? Someone new. I like it. Welcome.
Senator Bailey, members of the committee, my name is Benjamin Coolidge Gagnon. I'm with Sarah Public Affairs here on behalf of the Association of Dental Support Organizations, or ADSO. They're a nonprofit, national nonprofit representing dental support organizations that provide non-clinical business support to dental practices so dentists can focus on patient care. ADSO members support more than 15,000 dentists, 8,500 practices, across 48 states. ADSO represents DSOs before the public, policymakers, and the media. In Maine, for example, Aspen Dental, Heartland, and 42 North are all DSOs with collectively more than a dozen practice locations across the state. DSOs help dentists focus on clinical care of their patients instead of having to devote a large percentage of their time to procurement, legal, accounting, administrative, and facility management elements of running a small business. The DSO model of dentistry is the fastest growing support model in the industry, especially among new and recent dental school graduates. DSOs do not provide clinical services. All clinical services are provided by and under the supervision of dentists. The bill's definition of, especially as you've heard, management services organizations sweeps in DSOs, whose primary function is administrative support, not clinical decision-making. The DSO model, as I said, dentists remain the sole decision makers for all clinical matters, which is consistent with Maine laws governing the practice of dentistry and the Maine Dental Practices Act. DSOs do not provide dental services and don't interfere with the dentist-patient relationship. By requiring extensive advance notice, review, potential public hearings, and approval conditions for routine business transactions, like an agreement with a DSO, LD 2201 would create significant uncertainty and administrative burden for dental practices seeking to expand, partner, or transition ownership. These requirements would discourage investment and innovation in the dental space, particularly in rural and underserved communities that benefit from the DSO supported practices. Similar to concerns we raised in the prior legislation last year, overly broad transaction review frameworks risk slowing practice growth, limiting partnerships, and making it more difficult for dentists to enter or exit practice. If the legislature's intent is to oversee large, vertically integrated medical transactions, that objective should be pursued with precision, not by capturing DSO models that expand access, improve efficiency, and help address workforce shortages, which are especially acute in the dental space, as I think you all know. For these reasons, ADSO respectfully requests the committee amend the bill to explicitly exempt DSOs from its scope. If such an exemption cannot be achieved, ADSO urges the committee to vote on it to pass. Appreciate it. Happy to try to answer questions or bring back any information that can be helpful.
Thank you. I learned something new today. Any questions from committee members? Seeing none, thank you very much.
Thank you so much.
Anyone else wishing to testify in opposition to this bill?
Good afternoon, Senator Bailey and members of the Health Coverage Insurance and Financial Services Committee. Chris Ossenford, I represent Anthem Blue Cross and Blue Shield in South Portland. And I'm testifying in opposition to LD 2201, although it really was sort of a toss-up between opposition and neither for nor against. We do support, reasonable state efforts to look at provider anti-competitive practices, consolidation, and protect affordability. That being said, we're concerned that LD 2201, as other speakers have noted, may be overly broad and have unintended consequences with respect to the ability of providers to provide new services or establish new facilities. We agree. I like how Mr. Austin sometimes thinks I don't know what I'm talking about, but then thinks I do know what I'm talking about when he and I agree on something. What are you doing back there?
I'll just note that happens with my husband as well.
Oh, no. He's my legislative spouse? We believe that the definition of management service organization, for example, is extremely broad and probably should focus on majority ownership, not just any interest. We have actually several suggestions that unfortunately I didn't receive them until yesterday, so I did not have the opportunity to reduce them to writing, but I will be happy to provide those suggestions on ways to narrow the bill prior to your work session. And with that, I'm happy to answer any questions that you may have. And of course, we'll be at your work session.
Great, thank you. Questions from committee members? Seeing none, thank you very much. Anyone else wishing to testify in opposition to this bill? Anyone wishing to testify neither for nor against this bill? Last call, anyone wishing to testify on this bill in any capacity? Any requests from committee members for Colleen for the work session? Not seeing any, so I'll close the public hearing on LD 2201 and we'll open the public hearing on LD 2202, I'm assuming, an act to require notice to the Attorney General prior to the merger of certain healthcare entities as recommended by the Commission.
Yes. Thank you.
All right, good afternoon. Michelle Boyer, House District 123. Here to introduce LD 2202, an act to require notice to the Attorney General prior to the merger of certain healthcare entities as recommended by the Commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. LD 2202 requires a healthcare entity to provide notice to the Attorney General about a pending merger or acquisition at the same time the healthcare entity is required to notify the Federal Trade Commission or the United States Department of Justice Department's Antitrust Division in accordance with federal laws and regulations. And that's that. Happy to answer any questions.
Questions from committee members? Seeing none, thank you very much.
Thank you.
Anyone wishing to testify in favor of this bill? Wow.
Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Chris Ossenford. I represent Anthem Blue Cross and Blue Shield, and I am here to testify in support of LD 2202. Essentially, this codifies a requirement in state law to provide notice to the Attorney General. And my recollection during the commission meetings was that the Attorney General's office felt that this it would be helpful to have this provision in law and require that be provided with this notice. So with that, I'm happy to answer any questions, and I'll be present at your work session as well.
Okay, great. Thank you. Questions from committee members? Seeing none, thank you. Anyone else wishing to testify in favor of this bill? Anyone wishing to testify in opposition to this bill? Anyone wishing to testify neither for nor against this bill or in any capacity? You know, you can take some lessons from me, so Representative Mappa.
Pick and choose.
No, you chose to go first. That was your choice, just saying. Any requests for calling for the work session? Seeing none, we'll close. Okay, close the public hearing 2202, and then I guess Colleen has some language review and housekeeping stuff for us. Thank you.
So I just wanted to take 2 minutes. I didn't bring any other language review because I wasn't sure how long it would take today. But I did want to have you review the GEA letter so it can appear on Tuesday's calendar. So what you have is just the draft report of the committee, reflecting that the committee completed its review and evaluation of the State Employee Health Commission. You found that they are operating within their statutory authority pursuant to the review. And then the second paragraph is just kind of the extra stuff you said you liked about what the commission is doing in terms of evaluating, continuing evaluating the programs and analyzing them and making decisions, making changes based on that analysis and evaluation. So the first part is just standard language. The second paragraph is sort of my creative reflection of what you guys discussed. So I'd focus on that. If that looks okay, we can get this moving, and I'm happy to take any suggestions for changes.
Does that look good to the committee? Okay.
Okay, great. Thank you. That was all.
That's it?
That's it for me, yeah.
Wow. Okay.
Thank you.
Well, good job, everyone. Thank you very much. We are adjourned.
You know,